इस उम्मीद से है करो पोषण। मुख से झांकता है भारत का कल, अन्न प्राशन करो स्वस्थ बचपन करो, माँ का संसार हो दूध सा प्यार हो, आशा वाला नया एक जीवन करो, खोल के आंखें सपने खड़े सामने, सारे सपनों का मिलकर करो पोषणम, करो पोषणम, पोषणम 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 पोषणम, देश उम्मीद से है करो पोषणम, देश उम्मीद से है करो पोषणम, करो पोषणम, पोषणम 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 पोषणम, देश उम्मीद से है करो पोषणम। नन्ही नन्ही हथेली में आकाश है, पंख बेताब है उनमें विश्वास है, मुस्कुराती हुई बेटियां कह रही, देखो मंजिल का रास्ता यही पास है, कर रहा मिलके ये देश सारे जतन, कर रहा मिलके ये देश सारे जतन, पोषणम पोषणम पोषणम, देश उम्मीद से है करो पोषणम, देश उम्मीद से है करो पोषणम, करो पोषणम, पोषणम 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 पोषणम, देश उम्मीद से है करो पोषणम। ध्यान माँ का जो रखे जन्म वो सफल, बात छोटी सी है पर बड़ा है ये हल, स्वच्छ संसार में गूंजे किलकारियां, स्वच्छ जल में नहाएगा भारत का कल, संकल्प लेके चले आज हम, एक संकल्प लेके चले आज हम, चले आज हम, पोषणम 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 पोषणम, देश उम्मीद से है करो पोषणम, देश उम्मीद से है करो पोषणम, करो पोषणम, पोषणम 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 पोषणम, देश उम्मीद से है करो पोषणम, पोषणम 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 पोषणम, बिरंगा सब्जियों का कर लेना संतुलित आहार, सब मिली स्वस्थ बनाना बिहार, सब मिली स्वस्थ बनाना बिहार।
वाटिका घर में बनाकर रंग बिरंगा सब्जी उगाकर लेना संतुलित आहार, सब मिले स्वस्थ बनाना बिहार, सब मिले स्वस्थ बनाना बिहार।
अपनी क्यारी आप बनाकर फल और सब्जी उसमें उगाकर, समय समय पर लेकर प्रशिक्षण, समय समय पर लेकर प्रशिक्षण, आत्मनिर्भर करना परिवार, सब मिले स्वस्थ बनाना समाज, सब मिले स्वस्थ बनाना समाज। पोषण वाटिका घर में बनाकर, पोषण वाटिका घर में बनाकर रंग बिरंगा सब्जी उगाकर लेना संतुलित आहार, सब मिले स्वस्थ बनाना समाज, सब मिले स्वस्थ बनाना बिहार। पोषण वाटिका में हो हरियाली, सतरंगी रंगीन हो थाली,
वाटिका में हो हरियाली, सतरंगी रंगीन हो थाली।
अपना समाज आत्मनिर्भर बनेगा, अपना समाज आत्मनिर्भर बनेगा, तब होगा देश खुशहाल, सब मिले स्वस्थ बनाना समाज, सब मिले स्वस्थ बनाना समाज।
Horlicks Women's Plus. Stand strong. क्या हो रही?
मनोज, हम लोग स्टार्ट कर सकते हैं?
यस कर सकते हैं, बस पार्टिसिपेंट थोड़ा वेट कर रहे थे और रीच हो जाए। डियर पार्टिसिपेंट, जो भी अभी ज्वाइन कर चुके हैं, आप अपने कलीग, सहपाठी और जो भी स्टूडेंट्स फैकल्टी है उनको इन्फॉर्म करें कि इमीडिएट वो ज्वाइन कर ले। नो हम लोग अब विद इन 1 to 3 मिनट्स सेकेंड डे वेबिनार को आरंभ करने जा रहे हैं। सभी पार्टिसिपेंट्स से रिक्वेस्ट भी होगा कि हमारे आज का जो इम्पोर्टेंस, जो भी हमारे लेक्चर हैं, हमारे स्पीकर हैं, संबंधित जो भी क्वेश्चंस हो, आप ऑनगोइंग वेबिनार आप उसमें चैट बॉक्स में डाल सकते हैं और उस चैट बॉक्स में भी हमारे स्पीकर्स उनका आंसर कर सकते हैं। अदरवाइज क्वेश्चन आंसर सेशन में उनको रिप्लाई करने की कोशिश करेंगे।
हमारे मॉडरेटर्स आ गए हैं, कंचन एंड रुबीना।
यस यस, कंचन रुबीना जी ज्वाइन कर चुकी है।
यस मैम।
आप लोग अपना एक बार नेटवर्क देख लीजिएगा। हाँ,
यस मैम।
नेटवर्क के कारण थोड़ा मुश्किल हो रहा था। और दूसरा आप लोगों को ध्यान रखना पड़ेगा स्पीकर्स का टाइम।
यस मैम।
राइट, स्पीकर्स का टाइम थोड़ा ध्यान रखिएगा, 5 मिनट पहले उनको अलर्ट दे दीजिएगा। और नेटवर्क ठीक रहे। कल कल हम लोग को नेटवर्क के लिए बहुत परेशानी हुआ था। और दूसरा कि दो ये डिवाइस से मना कीजिएगा कि जिस लोग मोबाइल से भी कनेक्टेड होते हैं, लैपटॉप से भी कनेक्टेड होते हैं, उसमें साउंड बहुत इको होता है। राइट, तो और आपको लोगों को शेड्यूल मिल रहा है कब 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 कंचन तक कहाँ तक करेंगी, फिर रुबीना कहाँ तक करेंगी?
मिल चुका है।
वेरी गुड, प्रोफाइल में रन करा दूंगी स्पीकर्स का। राइट, ठीक है, ऑल सेट।
यस मैम।
गुड,
थैंक यू मैम।
अनुपा मैडम।
हाँ बोलिए ना मनोज।
डॉक्टर आशीष सिन्हा का प्रेजेंटेशन डॉक्टर विशाल या मतलब जहाँ से कंट्रोल हो रहा है वहाँ से शेयर होगा उनका।
ओके, आशीष सिन्हा ने मुझे भी भेजा है, एक मिनट देख लेती हूँ मैं। आशीष सिन्हा का तो बहुत अंत में है ना, आई थिंक इट्स गॉट लास्ट प्रेजेंटेशन।
यस यस,
देख लेती हूँ एक बार आशीष सिन्हा का।
प्रेजेंटेशन तो मिल चुका है ना?
मेरे पास नहीं है, उनका संजीव गोस्वामी का है।
ओके, मैं अभी जस्ट मेल कर रहा हूँ।
गोस्वामी का है, आप भेज दो मुझे प्लीज मनोज। राजेश गोस्वामी जी का तो Day 1 है ना इनका तो।
हमें लगता है आज का इस वेबिनार का शुभारंभ करते हुए इसके बाद बीच में हम पीपीटी शेयर कर देंगे मैम।
और ना उस वाले में कर देना मनोज, जिसमें हम लोग सब ग्रुप में सारे लोग को हो जा रहा है, तो इन केस मेरा कुछ प्रॉब्लम हुआ तो कोई बैकअप में रह जाएगा, है ना? तो उसी ग्रुप में कर देना, उस ग्रुप में ही कर देना।
नो स्टार्ट किया जाए
जी। May I start? Hello.
यस रुबीना जी, यस।
55 participants. Okay. A very good evening to one and all. It is our pleasure to be a moderator for NUTRIUTSAV Day-2. I am Rubina Parveen on the behalf of Indian Dietetic Association, Bihar chapter, with our developing partner, Alive and Thrive. I would like to extend a very warm welcome to all of you. We appreciate you all for sparing your time off your busy schedule to join us today, especially जब आज की शाम साल की आखिरी शाम हो. We hope we all learn a lot today. Like yesterday, today also we have a great and experienced expert panel who will deliver insight to the topics. To begin this program, I would like to request Dr. Manoj Kumar, Secretary IDA Bihar chapter, who will deliver the opening remarks. Dr. Manoj Kumar, over to you, sir.
थैंक यू रुबीना जी। सो आप सभी का आज के वेबिनार में, और यह आज वेबिनार का दूसरा दिन है, आप सभी का अभिनंदन करते हैं, स्वागत करते हैं। कल से हम लोगों ने न्यूट्री उत्सव 2020, जैसा कि कल हमने बताया कि न्यूट्री उत्सव 2019 में हम लोगों ने फिजिकल किया था, जो काफ़ी शानदार और काफ़ी सफल रहा था। काफ़ी सारे विषयों पर हम लोगों ने डिस्कस किया था और उसका इम्पैक्ट भी हमारे डेवलपमेंट पार्टनर्स और गवर्नमेंट एजेंसी ने इस चीज़ को रिकॉग्नाइज करके आगे उस पर काम भी करना शुरू किया था। कोविड-19 के सिचुएशन को देखते हुए इस पैंडेमिक सिचुएशन में हम सभी एक लंबे फेज़ से गुज़रे हैं और एक ऐसे सीन से गुज़रे हैं जो कि शायद हम सबों की उम्र में ये शायद पहली बार आया था। इन सारी को ध्यान में रखते इस बीच में काफ़ी सारे वेबिनार हुए, आईडीए के कंसर्न में भी काफ़ी वेबिनार हुए, हमारे डायटीशियन, न्यूट्रिशनिस्ट ने और हमारे काफ़ी सारे एक्सपर्ट भी आज जुड़े हुए हैं, उनके द्वारा भी काफ़ी वेबिनार का आयोजन किया गया, ताकि जो सिचुएशन है, उसमें कैसे हम लोग हैंडल कर सकें, उसमें डाइट का क्या इम्पोर्टेंस रोल है। निश्चित तौर पे कल भी एक हमारे पार्टिसिपेंट ने एक प्रश्न भी किया था कि डाइट का क्या रोल है इस कोविड-19 के सिचुएशन में, हमने उसका आंसर भी किया था। इससे साफ पता चलता है कि हम लोग कि डाइट का इतना इम्पोर्टेंट रोल है कि पूरे सेशन में हम लोगों ने डाइट से रिलेटेड इम्यूनिटी बूस्टर टॉपिक पर चर्चा किया और उसको अपने दैनिक जीवन में उसको ग्रहण भी किया। सो मैं आज के इस सेकंड डे वेबिनार में जो न्यूट्रिउत्सव जो इंडियन डायटीटिक एसोसिएशन बिहार चैप्टर में अलाइव एंड थ्राइव के साथ आयोजन किया जा रहा है। सर्वप्रथम मैं वेलकम करना चाहूँगा प्रोफेसर डॉक्टर फारूक अली सर का, ऑनरेबल वाइस चांसलर जयप्रकाश यूनिवर्सिटी छपरा बिहार। सर का अभिनंदन है। सर न्यूट्रिशन सोसाइटी ऑफ इंडिया भागलपुर के चैप्टर कन्वीनर भी हैं। इसके पूर्व में सर प्रो वाइस चांसलर बीएन मंडल यूनिवर्सिटी में प्रो वाइस चांसलर भी रह चुके हैं और हम सभी के मैक्सिमम काफ़ी सारे पार्टिसिपेंट्स जिनके टीचर भी रह चुके हैं। सो आपका अभिनंदन है सर सेकंड डे इस वेबिनार में। आपसे अनुरोध रहेगा कि आप पूरे सेशन को ऑब्जर्व करें। मैं अभिनंदन करना चाहूँगा आज के जो एक्सपर्ट हैं, हमारे जो स्पीकर्स हैं, हमारे डायटीशियन संजय मिश्रा, चीफ डायटीशियन पारस एचएमआरआई हॉस्पिटल पटना, आपका भी अभिनंदन है। आपको भी काफ़ी हमारे पार्टिसिपेंट लोग सुनने के लिए जुड़े हुए हैं और आपका समय-समय पर आईडीए को काफ़ी सपोर्ट मिलता रहता है। बीच-बीच में हम लोग सीएनई सेशन वगैरह करते रहते हैं, जिसमें आपका बहुत बड़ा रोल रहता है इस चैप्टर को आगे बढ़ाने में। सो आपका अभिनंदन है, स्वागत है। डॉक्टर सुभाष कुमार डायबिटोलॉजिस्ट, सेक्रेटरी आरएसडीडी बिहार, सर जाने-माने प्रसिद्ध डायबिटोलॉजिस्ट हैं पटना शहर के। सर का भी अभिनंदन मैं करना चाहूँगा। सर का भी आज हमें सुनने को मिलेगा। उनका काफ़ी एक्सपर्टीज़ है डायबिटीज़ से रिलेटेड में और टॉपिक काफ़ी रिलेवेंट है आज के समय में। सर का टॉपिक भी है कि कोविड-19 इन डायबिटीज़ माय रिसर्च ऑन पीपल ऑफ बिहार। सो आई एम वेरी एक्साइटेड कि सर हम सबों को शायद कुछ आज नया बताएँगे। सो सर आपका अभिनंदन है और हम उम्मीद करते हैं कि हमारे पार्टिसिपेंट आपका आज इस लेक्चर को सुनकर काफ़ी कुछ सीखेंगे। मैं अभिनंदन करना चाहूँगा मिस्टर प्रवीण कुमार जो प्रोजेक्ट डायरेक्टर हैं यूपी एंड बिहार के अलाइव एंड थ्राइव के। मिस्टर प्रवीण सर आपका मोस्ट वेलकम है आज के इस वेबिनार में, आपका अभिनंदन करते हैं। सर का भी आज टॉपिक काफ़ी लर्निंग फैसिलिटी बेस्ड क्वालिटी इंप्रूवमेंट न्यूट्रिशन सर्विसेज पे रहेगा। जिस प्रकार से ये इस वेबिनार का डिजाइन किया गया, निश्चित तौर से एक न्यू नॉर्मल जो हमारे आगे आने वाले समय में आफ्टर कोविड पैंडेमिक रहेगा, उसमें कैसे हम लोग सर्वाइव करें, कैसे न्यूट्रिशन जो फील्ड है वो कैसे आगे बढ़ेगा, न्यूट्रिशन में क्या-क्या इंपॉर्टेंस रहेंगे, किस तरह से, उसी प्रकार से इस टॉपिक को भी डिजाइन किया गया था। और हमारे एक्सपर्टीज भी जितने भी स्पीकर्स हैं काफ़ी अपने-अपने फील्ड के एक्सपर्टीज हैं। सो उनका हम सबों के बीच में आज उनका स्पीच होना अपने आप में हम लोग गौरवान्वित महसूस करते हैं। हमारे बीच आज स्पीकर के रूप में उपस्थित रहेंगी डॉक्टर अनुपम श्रीवास्तवा। उनका अपने आप में मैटरनल न्यूट्रिशन में बिहार के फील्डों में काम करने का काफ़ी अनुभव रहा है, जो कि सीनियर प्रोग्राम मैनेजर है अलाइव एंड थ्राइव का। मैडम का भी हम अभिनंदन करना चाहेंगे। डॉक्टर आशीष सिन्हा जो इंटरवेंशनल कार्डियोलॉजिस्ट हैं, सीनियर कंसल्टेंट हैं वैल्यू व्यू क्लिनिक कोलकाता में एंड के नर्सिंग होम भागलपुर में सीनियर कंसल्टेंट हैं। डॉक्टर आशीष सिन्हा का काफ़ी सारा एक्सपर्टीज है इस फील्ड में और सर से मैंने आग्रह भी किया था कि आज के सिचुएशन में जो कि काफ़ी हार्ट अटैक जैसे कोविड-19 के दौरान में ऐसा देखा कि कोविड-19 से जो ग्रसित हुए उसका हार्ट अटैक का रेट ज़्यादा बढ़ गया। खासकर ठंड के दिनों में हार्ट से प्रॉब्लम ज़्यादा बढ़ जाते हैं, तो ऐसे टॉपिक पर सर बात करेंगे। डॉक्टर आशीष सिन्हा का भी हम अभिनंदन करना चाहेंगे। और जितने भी हमारे स्पीकर्स हैं, साथ ही हमारा ऑर्गेनाइजिंग कमेटी के मेंबर्स हैं और हमारा इस ऑर्गेनाइजिंग टीम के चेयरपर्सन डॉक्टर प्रोफेसर प्रमिला प्रसाद, डॉक्टर ममता कुमारी चैप्टर कन्वेनर, ट्रेजरर हैं डॉक्टर संदीप कुमार, संतोष कुमार, डॉक्टर विधि कुमार सिंह, डॉक्टर महादेव प्रसाद साहा, ये हमारे पूरे आईडीए की जो ऑर्गेनाइजिंग टीम है और हमारी पटना की सारी जितनी भी टीम डायटीशियन न्यूट्रिशनिस्ट जुड़ी हुई हैं, हम सभी का अभिनंदन करते हैं और जो भी पार्टिसिपेंट हमारी जुड़ी हुई है उनका भी अभिनंदन करते हैं। सारे पार्टिसिपेंट्स से अनुरोध रहेगा कि आप जितने भी हमारे स्पीकर्स हैं काफ़ी मेहनत से अपना पीपीटी तैयार करते हैं और आप सबों के बीच में एक अच्छी नॉलेज को पहुंचाते हैं, आप उनका श्रवण करें और अच्छे तरीके से ग्रहण करने के बाद यदि आपके मन में कोई प्रश्न हो तो आप पूछ सकते हैं, चैट बॉक्स के द्वारा भी कर सकते हैं और बाद में भी आप क्वेश्चन आंसर सेशन में दे सकते हैं। सो आप सभी का अभिनंदन है, स्वागत है और पुनः एक बार आप सभी को अभिनंदन करते हुए मैं रुबीना जी एवं कंचन जी से मैं आग्रह करूंगा कि नेक्स्ट आगे इस आज के वेबिनार सेशन को आगे बढ़ाएं। थैंक यू।
Thank you so much, Dr. Manoj, for the motivating remarks. Okay, it seems many participants have joined the session, so we can start our scientific session. Just two things as a reminder I want to share before we get started. First, if you experience any kind of hearing problem issues in hearing today's webinar, you can join us through the YouTube link, which is already shared in the chat box first. And the second one, as Dr. Manoj already told, if you have any questions during presentation, please type them into the question box in your Zoom control panel or just note it down to ask at the end. We will have the question answer session at the end of presentations. So now without further ado, I would like to welcome our very first speaker for today, Mr. Praveen Kumar, Project Director, UP Bihar, Alive and Thrive, who will deliver on the topic learnings of facility-based quality improvement in nutrition services. Mr. Praveen Kumar Sharma, he is a public health professional having around 20 years of experience in public health and nutrition domain. Mr. Praveen previously worked for various public health projects like WHO India University Research Corporation LLC, Save the Child AED, and Ministry of Health and Welfare, Government of India. He is having experience of working with the private sector, medical training institutions, and professional medical associations to improve quality of care focused on reproductive, maternal nutrition, child and adolescent health. He is trained in Six Sigma and a Black Belt from American Society of Quality and holds master degree in public health and business management. Currently, he is working with Alive and Thrive as a project director, UP and Bihar. We welcome you, sir. Over to you, sir.
Thank you.
Sir, it is, yes, sir. Sir, it is requested to you to please try to compile your presentation in the given time. Thank you, sir.
Sure. Thank you. Thank you, Rubina. Thank you for my wonderful introduction. And first of all, I would like to congratulate all IDA team to organizing this wonderful workshop. And I want to thank you for giving me opportunity to share my experience specifically on quality improvement in nutrition. So thank you very much. I'm going to share my presentation myself. Please do let me know if you can see it.
Yes, sir. Yes, it is visible.
Okay, right. Thank you. So before starting my presentation, let me tell you the background about my presentation and my sharing today. So Alive and Thrive works across India, including UP and Bihar, are major focus area in UP and Bihar. So we are very closely working with medical colleges and private hospitals in Uttar Pradesh and Bihar. So we have provided technical support some medical colleges as well as private medical hospitals. Here I have an opportunity to share the experience where we work very closely with medical college and private hospitals for Bihar and the UP, and we learn a lot. And these specifically these medical hospitals has done a great job improving quality of care and nutrition. So yeah, so my topic is all related to the work has been done in Bihar and UP. So I want to start with few facts about how much poor quality contributes in mortality. So as we all know, like the undernutrition is a contributing factor for the mortality. So here, the Lancet Global Health Commission data reflects that healthcare in all global settings today suffer from high level of defects in the quality across many domains, including nutrition. Hospitalization in low middle income country leads to 134 million adverse events each year, and these adverse events contributes more than 2.5 million deaths annually. 5.7 to 8.4 million deaths occurs annually from poor quality of care in low middle income countries for selected set of conditions. For some conditions, deaths due to poor quality contributes to more than half of overall deaths. Across lower middle income countries, the cost of lost productivity alone due to poor quality care amount between 1.44 trillion and 1.6 trillion US dollar each year. So these facts is based on the study has been conducted by the Health Commission on high quality in health system and published in November 2018. So yeah, so these are the fact basically which we can see like how much this poor quality contributes to directly to the mortality as well as socioeconomic burden. Mortality due to access to quality and non-utilization of healthcare by condition type reflects huge portion due to poor quality. Poor quality contributes a major portion for neonatal and maternal deaths in low and middle income countries. If you see the neonatal deaths and maternal deaths here, so poor quality versus non-utilization of services, we can see it's a major portion where poor quality is contributing mortality. So here I wanted to share the WHO definition on quality. They have 6 dimensions on quality, which talks about health systems should seek to make improvements in these 6 areas. So what are these 6 areas where the quality need to be unpacked? The one is like the first one is effective services in terms of providing evidence-based care. The second one is efficient maximum utilization of resource and minimize waste, and the services should be accessible to the every person. In no condition, it doesn't matter the people are living in which geographical area or which settings. The service should be acceptable and the service should be patient centered. Patients should be given preference in terms of when providing services, and there should not be any constant or discrimination in terms of culture and the community. So the services should be provided as per their current practices, culture and beliefs. The services should be equitable is the next dimension of WHO, World Health Organization. So equitable services is very important, and there should not be any discrimination in terms of gender, race, caste, geographical location, or socio-economic status. The last one is which WHO dimensions talks about the safe services. The safe services is not only for the provider as well as the patient also. So this should minimize the risk and harm to the patient as well as the provider. So if we talk about the quality of care program across, so WHO also defined 4 major components in quality of care: the quality planning, quality assurance, and quality improvement. Quality planning talks about the setting clear priorities whenever a entire project or a program is being designed. Then these are the 3 major components need to be considered. The planning includes all the resources, all the manpower, all related terms like data system, capacity building, and other mid-course actions. Quality assurance will talk about the standard and regulations, internal and external measurements, setting action plans, and follow-up assessment. It's all related to the inputs, what inputs need to be done to provide the services, which includes all like the training, the infrastructure, the resources, and standard protocol, of course. The third and major important component is quality improvement. Here I wanted to share the experience on the quality improvement which these medical college hospitals has done in Bihar and Uttar Pradesh. So quality improvement is all about the improving the processes of providing services. So the major component of quality improvement is setting targets, analyzing problems, developing solutions, and using PDSA to test the changes which is being applied. I wanted to share this ROW study, and ROW in 2015 reviewed 829 studies on effort to improve healthcare health worker performance. So they wanted to see that what are the different component where we can see to improve health workers performance. So they analyzed the print material which has gone up to the 10%, like they they cleared some misconceptions also this print by while reading this print materials, the health workers, and their knowledge level has increased up to 10%. Training has been increased up to around 25%, their work performance. Supervision also contributed up to 20%. Training and supervision both has contributed around 30% of health worker performance. So these all study based on 829 projects studies has been reviewed by ROW. So basically what is the new routine system is like, if anybody and any performance, if any indicator is not improving, the training, the supervision and training supervision, as well as IEC and SBC providing IEC and BCC material is very common. So in this study we can see, yes, these are real, improve the performance, but not up to the mark. If we talk about the quality improvement is all about the improving the processes, improving the system, identification the problems, system related problems, and improving the system related problems. So the study has suggested, like, up to 70% workers performance has been increased by applying the quality improvement approaches. So here we can see, like, what is quality assurance and what is quality improvement. So these are the two important component if we wanted to improve any services in facility. Quality assurance is all talk about the problem after they occur. Also it's externally driven, because these are being monitored by external people to assure the quality. Periodic measurement of past performance, again, not the current, what has happened previously, quality assurance measures and meet standard. Quality improvement is all about the current practices, identification the problems in the current system. It is all internally driven by the team, those who are really providing the services. It's all about learning from the continuous processes and what the care is being provided, and it exceeds expectations also. So this was the practical things I talked about. I shared few data and research studies regarding the quality improvement. Now I wanted to share the experience what the medical college actually has done. We as 11th has provided the technical support and training to use the quality improvement approach to improve the maternal, infant, young child and nutrition services. So what is quality improvement and what we did actually? So quality, as I earlier said, quality improvement is talk about the identification, the gap between the current state and what we want in the desired state. So what is in between? So the quality improvement try to identify the gaps and the opportunity to the improvement. So there are three major components. It's a very famous Donabedini model, which he developed on 1980. The three things is in any system is there, like people, infrastructure, material, information technology. This all are structure, or we call it the inputs. The activity and the processes is what is done and how is done. Here the quality improvement approach is being applied, and the result we expect improved health services and patient satisfaction. So what these medical colleges, which I'm going to share the very good results from there, has applied the quality improvement approach. So what this quality improvement approach has been adapted from the point of quality improvement intervention. And this has been introduced by WHO, government of WHO and All India Institute of Medical College and USA Research Project. Later has been adapted by Ministry of Health and Family Welfare and is being used in Lakshya program to improve the care in medical colleges and district hospitals. So this is a quality improvement approach. We have provided a training to the medical college staff and the service providers, And there are 4 major steps here to in this point of care quality improvement approach. The one is identification of problem, forming a team, and writing an aim statement. The second step is analyzing and measuring a quality of care. Third step is developing and testing the changes. Fourth step is sustaining the improvement. So these 4 steps has been applied for various medicine services in these medical colleges, and they got a very wonderful result. So here I wanted to share the improvements from All India Institute of Medical Sciences, Patna, Bihar. They have been trained initially for a point of care quality improvement approach, and they analyze their system, what exactly is needed and what they wanted to improve. So initially they have chosen that they are facing the problem related to the early initiation of breastfeeding in C-section, complication free C-sections. So they wanted to improve early initiation of breastfeeding in C-section areas. The training has been provided in July month. They have identified their system and they put some small changes. Like the first thing was there to the training has built their confidence, like, yes, they can do it, and EIVF could be done in C-section also. They have applied very small changes, like, engaging attendants, patient attendant to support in EIVF. They have deployed a specific staff nurse for doing the EIVF in OT, and they made some sequential changes in the process where who will do what, and also the important thing is they started to record the data also, because earlier they were not recording the data, how many newborns are being breastfed and or not. So they started small changes. They tested the changes, and you can see the result here. Since July to the data is for 2019, and since July to November, they improved they reached from 0% to 80%. The same story is with from the Bihar again, Gaya Medical College, Bihar. They also chosen to improve the EIVF in C-section. They made a small changes, assigning responsibilities, and some process related changes, and now they have reached around 80% to 90%, where they are providing EIVF in C-section in their hospital. PMCH Patna, they have first started to improving the EIVF in normal deliveries. So they have taken this as a 0 because they don't have any record earlier as a baseline what is the current status for EIVF in normal deliveries. So in June months, the training has been provided, and they have started collected the data, and they have reached in few months 80% babies are now being breastfed in PMCH Patna. So here you can see again, this is from the private hospital, Tripolia Hospital of Patna. They have started early initiation of breastfeeding in both areas, in C-section and the normal vaginal delivery. Again, the problem was related to the data, but they know that yes, there are the gaps in providing the EIVF in their hospital. So in August month, they have been trained, and again, they have improved a lot in next 4-5 months. So they applied these quality improvement approach in normal to improve the normal as well as C-section deliveries. This data is from GMC Kannauj Medical College in Uttar Pradesh, where they also selected to improve EIVF in normal vaginal delivery, and they also got very encouraging result in few months. So beyond the early initiation of breastfeeding, Kanpur Medical College wanted to improve the antenatal care services in their medical colleges. And there were a lot of barriers. They again don't have a data related to the height, BP measurement and HB measurement, as well as the counseling in their hospital. They had a data related to the weight measurement in their hospital. They applied this quality improvement approach since May 2019. And so it's a huge number over there, around more than 500 deliveries load is there, and they significantly improved all these antenatal care services in few months. This data is from BRD Medical College, Gorakhpur. where their NRC is already established and SAM were earlier identified, but there was no proper recording for the SAM identification, but as well as they were not identifying the MAM. So they choose to improve the screening of undernutrition children in the hospital, and they again applied these process related changes and improved around till, and they could identify around 20% of MAM out of total those who were coming to the OPD. So I wanted to share a few lines from the father of quality improvement. His name is Dr. William Edward Deming. Many of you have already listened her name. He says like quality improvement is a science of process management. It's not about the monitoring or penalizing the providers. So identification of problem related to the system and related to the processes. Measurement is a very important component. So if we wanted to improve quality services, any services in the hospital, we have to measure the services. We should have a baseline, and we need to track where we are going. Are we going in the right direction or not? The third thing is what Deming was saying, like management of care means managing a process of care, not managing a physician or nurses. So the new usual things are there is we see like the monitoring and managing the physician and nurses. We often consider the to manage the processes, identification, the problem related to the processes. Data use is very important. So what Deming is suggesting, that the right data in the right format at the right time in the right hands should be there, so that this could be tracked, like where we are going, what we are doing, the service we are providing is it is good or bad direction, we are improving or not improving. So that is very important. Engaging the smart cogs of healthcare, we have to identify which are the small contributors, small events or small interventions which contributes to the larger scale to improve the healthcare services. And so if we apply any quality improvement approach, there are many things we see, like the small intervention and these small changes provides an impact to a larger impact as a outcome. These are the few pictures, because many of the medical college has chosen to improve the AIVF, early initiation of breastfeeding in C-section, and these are from the medical college from Bihar only, and they improved a lot. Yeah, so this is all about the quality improvement approach has been applied by the medical colleges and one of the private hospital in Bihar. Thank you very much.
Thank you, sir. Thank you so much. Thank you so much, Mr. Praveen, for such an informative presentation. Just a reminder, please be sure to type your questions into the question box in your control panel. Thank you.
So are we taking the question now, or are we taking the question after finishing?
No, sir. After presentations, all
Okay.
presentations.
Okay.
Okay. Okay. For the next presentation, yesterday, Madam Jagmeet had explained that the preventive diet management is more important than the curative diet. But when you are suffering from any kind of disease, it becomes compulsory to follow a curative, or we can say a corrective diet, right? So when we talk about the disease condition, two most prevalent diseases come in our mind, that is the diabetes and hypertension, the heart diseases, which require the medical nutrition therapy, that is the MNT, which is very important to prevent, managing, and the control of their disease complications. To give the light at the topic dietary management in diabetes and hypertension, I would like to welcome our next speaker, Mr. Sanjay Kumar Mishra, who is a chief dietitian and head of the Department of Nutrition and Dietetics, Paras HMRI Hospital, Patna, Bihar. He is a regional officer, Indian Association for Parental and Enteral Nutrition. he is having more than 23 years of experience in the field of clinical nutrition and dietetics in different field like government and public health, public sector organizations like Government of India, Ministry of Health and Family Welfare, UGC Academic College like Niranjana Institute of Medical Sciences, Kalinga Hospital, Bhubaneswar, and he is right now he is in Paras HMRI Hospital, Patna. Over to you, sir.
Hello.
Yes, sir. Audible.
Uh,
You are audible. Yes, sir.
Thank you. स्लाइड दिख रहा है?
Yes, sir. Your slide is visible. Yeah.
Okay, thank you, Rubina ji, for your kind introduction. And
Thank you, sir.
respected.
Sir, we love to hear you
Sir.
always.
Sorry.
We love to hear you always.
Oh, thank you, madam. So, respected Professor Farooq Ali sir, Professor Mahadev sir, Professor Pramila madam, Professor Mamta madam, Dr. Manoj, Parveen Kumar ji, Project Director of Alive and Thrive, and entire team of IDA Bihar chapter. Really, it's a good moment for me to share my view with you all regarding the diet management in diabetes and hypertension. So just this one is a very common topic, and generally we all face, that means the few cases regularly in related to diabetic and other metabolic disorder diseases. So just as a per theme, that's the webinar theme, that's maintain healthy life through balanced nutrition. So this one is a very, very important topic. I think we all will benefited with the discussion, and definitely we have also a good revision with all the topics and all. So just as we know, that's the burden of major non-communicable disease in India. That's the 35 million cases of cardiovascular diseases, 45 million cases of diabetes, 2.4 million cases of cancers, 22 million obesity, 1 million cases of cerebrovascular diseases. So that means every fifth diabetic is an Indian. That's the great challenges for all of us. Every 5th to 10th Asian Indian native urbanite is a diabetic. So diabetic is one of the major challenges for all of us. So just today we are going to discuss, we all know that, just simply enlighten the things. So what is diabetes? So this one is a very common thing we all know, but just I recap here. So diabetes mellitus is a silent chronic disorder characterized by elevated blood sugar level, either due to defective insulin secretion or action or both. So we all know that किसी तरह से यदि इंसुलिन का सिक्रिएशन प्रॉपर्ली नहीं हो रहा है, या यदि हो रहा है तो उसका प्रॉपर्ली यूटिलाइजेशन नहीं हो रहा है, या दोनों ही कंडीशन में, उसको हम लोग बोलते हैं कि इस कारण से कभी ब्लड शुगर हाई हो जा रहा है और कभी ब्लड शुगर लो हो जा रहा है, तो समझते हैं कि ये डायबिटिक हो गया. जस्ट इसको हम लोग इस ढंग से देख रहे हैं, ग्लूकोज इन द करेंसी ऑफ द बॉडी एंड एवरी सेल नीड्स इट. सो जस्ट यू सी हियर, ग्लूकोज, इंसुलिन का क्या रोल है? इंसुलिन जस्ट एक्ट एज हेयर कैटलिस्ट, ग्लूकोज को लेकर के सेल के अंदर डाल रहा है. सो जस्ट, और हमारा सेल जो है उस ग्लूकोज को यूटिलाइज कर रहा है. व्हाट हैपन व्हेन पेशेंट विल हैव डायबिटिक? दैट मींस इन दैट केस ग्लूकोज हम ले तो रहे हैं, बट सेल उसको जो है, सेल को एब्जॉर्ब नहीं होने दे रहा है, उसमें इंसुलिन जो है सो रजिस्ट कर जा रहा है. और दिस वन इज द वन ऑफ द मेजर थिंग फॉर डायबिटीज मेलिटस. We all know, just simple recap here, we all know that's the different type of diabetic, type 1, type 2, malnutrition related diabetes mellitus, impaired glucose tolerance, gestational diabetes. Just simply I recap. So risk factor, we all know that's heredity is the one of the major risk factor, obesity, lifestyle modification, aging, increased catabolism, infection, stress, maternal factors. These all are the risk factors for diabetic. And the major symptoms of diabetes: excessive thirst, increased appetite, frequent urination, loss of weight, easy tiredness, slow healing of wound and cuts. So these are the very common symptoms. We all know that. Just I recap here. Now just you see, what is the diagnostic criteria for the pre-diabetes level and diabetes level. So just you see the parameter here, the fastings less than 100 milligram per DL this one is the normal blood sugar level, and 100 between 100 to 125, this one is the blood sugar level in pre-diabetes stage. When blood sugar level in between, so just we can consider as pre-diabetes stage, and when blood sugar level is more than 126 milligram per dl, so that means you may say the patient is in diabetic stage. Similarly, after 2 hours of eating or random blood sugar, so normal blood sugar is less than 140 milligram per dl, or blood sugar level in between 140 to 199, so just you may say that's the pre-diabetes stage, and if more than 200 milligram per dl, then patient will have diabetic. So HbA1c less than 6, we can say normal blood sugar level, and blood sugar level HbA1c level if between 5.7 to 6.4, in that case you may say in pre-diabetes stage, and more than or equal to 6.5, that means the diabetes level, percentage in diabetic level. So this one is a very common thing, just we have to we have to remember always. The few complications that's always related with the diabetic, that's the hypoglycemia, ketoacidosis, and infection. That's the very common and common complications with diabetic. Chronic complications, we all know that's the neuropathy, nephropathy, cardiomyopathy, retinopathy, high blood pressure. These are the very common complications in diabetes. So now just the topic we are going to discuss, that's the management of diabetes. What our target, what's our objectives? So our main objectives to reduce this blood sugar, reduce the blood sugar level and sugar level in urine. Second, to maintain ideal body weight. This one is a very, very important things. Treat the symptoms. We can't treat only diabetic. We treat the symptoms if any other related to diabetic. Reduce serum lipid, provide adequate nutrition as per the requirement of the patient, and avoid acute complications related to diabetes. So these are our objectives. We have to consider when we are going to plan a balanced diet for our patients. So what's the mode of treatment? That's a very, very common, and that's a very interesting. Generally, I always share with each and every speech when I am going to discuss regarding diabetics. So that is called DEM, D-E-M. D for diet. Diet is one of the major prime important major important role play in diabetes management. Second one is the exercise, and third one is the medicine. So that means we can say you first of all, when you have diabetic, you go with the diet, and then completed with exercise. If not control, then we'll go with medicine. So DEM is the very common. We combine together diet, exercise, and medicine. That's the very, very effective. But generally in Indian scenario, it's happened only reverse of that. That is the MED. And MED is the short form of medicine only, nothing else. So we have to educate our patient and their relatives. That's a very, very important. We never go with MED only. Always go with DEM. That means diet, exercise, and medicines. So we have to educate our patient and their relatives also to do diet, exercise, and medicine properly to manage diabetic. When we are going to plan diet for our diabetic patients, so we think regarding that. What is the factors that's very close related to patient? That's the age factor, gender, male or female, height, what's the patient's height, what's their weight, what's their activity, physical activity. That means patient is in sedentary activity or moderate activity or heavy activity, which kind of worker they have, physiological status, what is their physical status. And accordingly, we have to take decision how much calorie is required for our patient. So in general, that's the maximum dietitians and endocrinologists or diabetologists have their thought just we have always give the low calorie diet for diabetic patient. That's not true. Always we go through the proper dietary management, proper nutritional requirement of our patient. So boys up to 18 years, generally we give 1000 kilocalorie plus 100 kilocalorie for each year. Suppose patient age is 10 years only. So in that case, you can give 1000 plus for 10 years, 100 into 10. So that means 1000, that is total 2000 kilocalorie for 10 years boy. If boy is 15 years old, so you can give 1000 kilocalorie plus 100 into 15 kilocalorie, that means 1500. So total calorie 2500 kilocalorie for 15 years boy. Similarly, when patient is in girl, only 10 years old, in that case, you may give 1000 kilocalorie plus 80 kilocalorie for each year. That means 800, 18 to 10, 800 plus 1000, that is 1800 kilocalories. So you can see the differences. When 10 years boys, you are going to give the calorie requirement, that means the 2000 kilocalorie. For 10 years girls, you are going to give 1800 calories. So just you see the gender differences. Then that's the adult overweight patient, you may give 20 kilocalorie per kg of ideal body weight. Ideal body weight, those patient who have ideal body weight and sedentary activity, in that case you may give 30 kilocalorie per kg of ideal body weight. And if that's the patient is in moderate worker and heavy worker, accordingly you may increase the calorie requirement. Similarly, patient is in underweight, in that case you may give 40 kilocalorie per kg of ideal body weight, and during pregnancy you may give 30 to 35 kilocalorie per kg of ideal body weight. So calorie requirement and fulfilling the requirement, that's our one of the major challenges. So first of all, we can take decision regarding that, what's the patient's calorie requirement. Secondly, we have discussed regarding ideal body weight. So just go with simple formula. For male, we may calculate height in centimeter minus 100. So suppose one patient's height is 165 centimeters. So in that case, minus 100. So that means 65 kg his body ideal body weight. So 65 into 30 for sedentary activity. Accordingly, you may calculate their calorie requirement. For female also, height in centimeter minus 105. So if suppose female height is also 165 centimeter, in that case 165 minus 105, that means 60 kg is the ideal body weight for female. So we have to take ideal body weight accordingly, and then you give the calorie requirement to our patient. Second thing is the body mass, as per body mass index. So just we all know the formula, weight in kg divided by height in square meter square, and accordingly we may decide that's the percentage in overweight or obesity or underweight, and then we can provide the calorie to our patients. So as per physical activity, already we discussed. So there's a sedentary activity, so 30 into ideal body weight. Moderate activity, 40 into ideal body weight, and heavy activity, that means 50 into ideal body weight. This one is the calorie requirement for diabetic patients. So that means as per physical activity, the calorie requirement vary. As per age, just you see, if the patient's age is between 40 to 49 years, in that case, whatever it may be the calorie requirement calculated, minus 5% of total calories. Suppose sedentary activity, 60 kg ideal body weight, male. So you can multiply with 30. So 60 into 30, 1800 kilocalorie. But the patient age is patient age is between 40 to 49 years. In that case, you can minus 5%. So that means the 5% of 1800, that means 90 calorie minus. So that means you may give 1700 kilocalories. Accordingly, you may calculate. So when patient age in between 50 to 59 years, in that case, minus 10% of total calories. Patient's age in between 60 to 69 years, minus 20% of total calories. And if the patient age in more than 70 years, in that case, total calories, minus 30% of total calories. So calorie requirement, just at first you have to take, then accordingly, you have to give diet plan to your patient. But in entire day, how you are going to distribute the total calorie. So we have to consider in breakfast, during breakfast, 25% of total calorie. Mid-morning, that means between breakfast and lunch, we may give 5% of total calorie. During lunch, we may give 30%. Evening tea and snacks, we may give 10%. Dinner, 25%. And bedtime, 5% of total calorie. For example, suppose you are going to give 2000 calorie for your patient. So 2000 calories, 25%, that means the 500 calorie at breakfast, 5%, that means 100 calorie at mid-morning. During lunch, that's a 30%, that means 600 calorie during lunch. Evening snacks, that means 10%, so 200 calorie during snacks. And dinner again 25%, that means 500 calorie in dinner, and bedtime 5%, that means 100 calorie at bedtime. So this distribution is very, very important for our diabetic patient to control diabetes mellitus. So how we how we give the carbohydrate, protein, and fat distribution of total calories. So always we give 60 to 65% of total calorie through carbohydrates. As we know, in generally 75 to 80% population's diet is fully depends on carbohydrates. So in that case, when patient will have diabetic, we have to suggest them to take maximum 60 to 65% of total calories through carbohydrates. And always keep in mind the carbohydrates is in complex form. That means complex carbohydrate form. We always try to give the simple sugar restriction. Protein between 15 to 20%. That's a lots of patients. Just we have a discussion with the patient, and they told just sir, many dietitians and physicians says that कि आप ज़्यादा दाल मत खाइए, उससे क्या होता है, ज़्यादा प्रोटीन मत लीजिए, उससे आपका यूरिक एसिड बढ़ जाएगा. So just we have to consider such kind of myths also. That's not the major cause of that. That's the other reason behind this. So we have to give 15 to 20% of total calorie through protein and 20 to 25% of total calories through fat. So just 100% divided in carbohydrate, protein, and fat accordingly. That's up to your patient's food habits, and that fully depends on your judgment how much protein, carbohydrate, and fat you are going to give your patient. Cholesterol maximum 300 milligram per day, and fiber in regular diet minimum 25 to 35 gram per day we have to prescribe for our diabetic patient. Sodium, that means salt, natural salt, that's one of the major source in our day-to-day diet. So that is normal. But when patient will have hypertension, we have give just restriction of total salt. Vitamins and minerals normal, and alcohol. Alcohol, that's the many patients ask regarding that. So that's less than or equal to 5% of total calorie. How you calculate 5% of total calories? So that's the best example is 2000 calories. Suppose a 2000 calorie diet chart you are going to provide. So 5% means 100 calorie, and 1 ml of alcohol is provide approx 7 kilocalories. That's the empty calorie. So that means 100 divided by 7. So approx 14 ml alcohol you may prescribe to your patient. Now just you see, ask your patient which brand they prefer. Generally that's the whiskey content 40 to 48% of alcohol. So that means you are going to give, if 100 ml, that means 40 ml alcohol. 100 ml of whiskey contain minimum 40 ml of alcohol, and you are going to give only 14 ml per day. So that means divided by 3. So that means you can suggest your patient maximum 30 ml you may have per day, not more than that, if patient ask you related to alcohol. Okay, so that's a very simple thing. Just you have to never say no, just always go with the proper way. Yes, you may have, but maximum 30 ml per day. So distribution of nutrients, as we discussed. So carbohydrate, we may give in the complex carbohydrate forms, in the cereals, pulses, whole grains. These are the one of the major sources of complex carbohydrate. We have to give the restriction of simple sugar like sugar, jaggery, honey, glucose, etc. Proteins are vegetable source. Protein from vegetable source are better than from animal source, as they do not contain cholesterol and rich in fiber. So just we may always give the preference of vegetables protein, but complete protein should be given to our patients. So how you make the complete incomplete protein to complete, we all know that. So just vegetables and pulses, combination of vegetables, combination of cereals and pulses is one of the best source of complete protein. So we may suggest to our patient with lunch and dinner both. That means they have to take pulses with cereals, whatever it may be. They are taking rice or chapati. I will discuss regarding that in next slide. Fats, that's the fats from vegetable sources are better than from those from animal sources, and 15 to 20 grams of vegetables fat per day recommended for diabetic patients. You may increase or decrease as per the total calorie requirement and total percentage of fat you are going to prescribe to your patient. Vitamins and minerals, diabetics during infection and other complications may require higher amount of vitamins and minerals in the form of supplements. So you have to take care for the same. So choice of a healthy cooking medium, that's the very common question in day-to-day patient dealing. So a consumer is confused. That means just you may say a patient is confused a lot as far as choosing the right kind of cooking medium is concerned. Every supplier of any type of cooking oil claim the same to be best for health. a common man is not aware of the yardstick by which any cooking oil should be rated as the best one. So they always confused, and they maximum time they ask dietitians for the same. So just which oil is better to use? So that's my view. Mustard oil has about 60% monounsaturated fatty acid. That's the 42% uric acid and 12% of oleic acid. 21% polyunsaturated fatty acid. That's the 6% omega-3 and alpha linoleic acid, and 15% omega-6 linoleic acid, and about 12% saturated fat. This one is the composition of mustard oil, as we know. Olive oil has about 73% monounsaturated fatty acids, mostly oleic acid, 13% polyunsaturated fatty acids, mostly omega-6 linoleic acid, and about 14% saturated fatty acids. Okay, so just you see the comparison between mustard oil and olive oil, because olive oil is called one of the best oil available in the market. So just you see the comparison between mustard oil and olive oil. So most of the researchers have proved that mustard oil is healthier than olive oil. That's my view is also due to its ideal ratio of fatty acid and natural antioxidant, polyphenols including gallic acid, caffeic acid, quercetin, and camphorol, which helps in free radical escaping, metal chelating, and blanching cholesterol level that make healthiest edible oil, which huge benefit on the heart. So that's my view is that always go with the mustard oil as a cooking oil, and when you are going to take sometime paratha and any oily foods, in that case you may use olive oil. Okay, so that's my view, and I am suggesting my patient also. Dietary fiber, that's one of the major important nutrient for diabetic patient. Fiber present in vegetables, fruits, legumes, and fenugreek seeds is soluble in nature and more effective in controlling blood sugar and serum lipids than the insoluble fiber present in cereals and millets. High fiber foods have a low calorific value and low glycemic index. So just we have to give high fiber diet to our patient. So just some dietary fiber content some foods. Just you see rice contain 0.6% of fiber, but wheat contain 1.7% of fiber. When we are going to compare with ragi, that's the one of the best and richest source of fiber content. Similarly, in pulses, just you see arhar dal and rajma. Rajma is the best, and arhar dal is the second. Arhar dal is the second best fiber content. In vegetables, all vegetables are the good source of fiber, but parwal is the best source of fiber when you are going to compare with even Karela. So that means just far, that means very low fiber content in Karela when you are going to compare with parwal. So just always keep in mind, just say only Karela to your patient, always suggest to take parwal. So that's they always patient love to take parwal when compare with Karela and others. So just always give the preference to the patient as per your choice. You may have any kinds of vegetables and the fiber rich foods. Dietary fibers in roots and tuber, just you see a carrot contain 1.2 gram of fiber, and that's the highest in other roots and tuber. Nuts and oil seeds, that's the highest in supari, but we can't suggest to our patient to take supari a lot when we are going to compare with almond and others. Okay, that's very, very important. So during, regarding fruits, just you see guava is the one of the best fiber content, that's the 5.2. So here there's a lots of confusion in the patient ki just ripe guava nahi lijiye, kacha guava lijiye. These are only confusing to your patient. Always suggest to patient just whatever it may be available in the market, go with the seasonal fruits, and when you are going to take guava, that's the best, either ripe or raw. That's not given much more difference in that. Similarly, grapes. That's lots of confusion. You can't take grapes. Just you see what's the fiber content in grapes, and I will again compare with the total calorie content. So just 2-3 things we consider for diabetic patient: low glycemic index, high fiber, and low calorie content. So just you see grapes. Always we suggest to patient take plenty of jamun, but no grapes. So just always see all these things, and accordingly we have to plan for our patient. Just to see glycemic index for all cereals are more or less same between 70 to 72. But in cereals, rajma is the best, only 29. Other also legumes is maximum 48, 49. So that's means less than 50. So what happened when we are going to combine cereals with pulses, not only improve the protein quality, as well as we are going to reduce the glycemic index. So always rice and legumes are, cereals and legumes are the best choice for our patients with the plenty of vegetables. Just you see the glycemic index of sweet potato in Odisha, generally sweet potato added in the mixed vegetables, and that's give the good taste to our patient also. But generally in Bihar, the patient is taking sweet potato just boiled and take it. So always suggest to your patient, you can take as a salad. That's not give any harm impact on your daily diabetes control. You may mix with the vegetables, that will give the good impact, but you can't take boiled sweet potato. That's very, very important. So such kind of education we have to provide to our patient. That's give the really better impact in our patient. Similarly, fruits, just to see the glycemic index of apple, that's very low, but the glycemic index of banana is very high. Similarly, orange, many of dietitians say, no orange. So just we have to give the total quantity, restricted quantity, but we never say no, and no. Always you give to the patient restricted quantity and allow maximum foods or fruits, whatever it may. That means you feel better within the calorie requirement and other requirements we are going to give. So, food exchange. Just before discussing the food exchange, just regarding cereals and pulses, just we have a lots of discussion. And the one myth is there: you can't take rice if you have diabetic. So, have you seen there? Glycemic index more or less same, fiber content little bit differences, and third thing is that's the total calorie content more or less same. So that's not give the much more difference in rice and chapati. Just you give preference to patient as you like, you may have, but total quantity should be restricted. Whatever it may be calorie you are going to give to your patient, just you may suggest to your patient that this much quantity you may have, no need to take more than that. So exchange formula, when we are going to exchange, you may exchange with the cereals. So food exchange, cereals 30 grams, and that's provide energy 100 calorie, carbohydrate 20 grams, protein 2 grams. So any kinds of cereals as per patient choice, you may say whatever you may prefer, you may have, but this much of quantity as per their calorie requirement. Similarly, anyone they may exchange pulses and legumes. That's here 30 grams of pulses and legumes is provide 15 grams of carbohydrate and 6 grams of protein with 100 kilocalories. So they may exchange with any kind of pulses, whatever it may available with them. Never bound with you can take only such kind of dal, this, that, etc. Similarly, vegetables, leafy vegetables and other vegetables as per patient choice. Just you give their choice. आपको जो पसंद हो, जो available हो, आप उसको ले सकते हैं. Root vegetables exchange. Sometimes patient want to take root vegetables. So in that case, just you see, that's provide 50 calorie and 10 grams of carbohydrates. Only 30 grams of potato provide 50 calorie and 10 grams of carbohydrate. But when you are going to compare with the beetroot, so that is 75 grams of beetroot provide only 10 grams of carbohydrate and 50 calorie. So that does not make many changes. So you may suggest to your patient that they may have beetroot and carrot also. Just you see that that's a less calorie content than onion, carrot. So just you may say in salad, you may have plenty of beetroot and carrot also, because their glycemic index is also low, their calorie content is also low, and they are rich in fiber. So just during in salad, they may have plenty of carrot and beetroot, but try to avoid gajar ka halwa, carrot halwa. Okay, that's give the negative impact in the patient. Similarly, fruit exchanges, already we discussed regarding the glycemic index and fiber content. Just you see here the carbohydrate content, carbohydrate 10 grams. So it is provide 50 calories. So when you are going to take 75 grams of apple, that's equivalent to 30 grams of banana and 30 grams of date. But when you are going to take grapes, that's 105 grams of grapes provide only 10 grams of carbohydrate and 50 kilocalorie. So in season, during season, patient want to take grapes. You can say, yes, this much of grapes you may have, because that's rich in fiber, that's the glycemic index is also not so high in that case, and calorie is also very less. So you may say, yes, you may have grapes, but this much of quantity, and in which time that's the decision taken by you. And I think that's the mid-morning, that means between breakfast and lunch, that's very, very important for them. So just we may suggest them accordingly. Just you see the guava also, that's 100 gram, that provide 10 gram of carbohydrate and 50 gram of 50 kilocalorie. Similarly, just you see jamun. Blindly we may say jamun, but 50 grams of jamun provide 50 kilocalorie and 10 gram of carbohydrate. Similarly, mango ripes, watermelon 270 grams. So just you may suggest to the patient, आप आम खाना किसने भी पेशेंट को बंद कर दीजिए, पेशेंट बंद नहीं करता है, बट यदि आप उसको बोलेंगे कि ठीक है, just you may have just one slice of mango in during this period, they may enjoy and just they say कि just हमारे डाइटिशियन ने कहा है, तो उनका एक कॉन्फिडेंस लेवल भी रहेगा, within calorie limit they may have, so that's not give the many negative impact in their day-to-day diabetes control. Similarly, milk exchange, just you see the 5 gram of protein and 100 kilocalories. So buttermilk, that's a 750 ml, so that's your best choice. Cheese only 30 grams, curd 210 grams, khua only 30 grams. So just you see here, skimmed milk powder. Many dietitians and endocrinologists or diabetologists also suggest you may have milk powder. So never suggest milk powder. You may say them to take either cow's milk or skimmed milk. That's always give the better impact on that. And buttermilk is the first choice for diabetic patients. So milk, whatever it may be, the exchange formula is always give the lots of option to our patient, and we go with our patient with details, proper nutrition education. That very, very important for us and our patient also. Similarly, when we are going to discuss regarding flesh foods, so just flesh food, just to see, this provide 10 gram of protein and 70 kilocalorie. Big fish 60 grams, a small fish also 60 grams. But many of us say no big fish, you may have a small fish. जब हम बताते हैं कि मछली का ऑयल भी आपके लिए फायदा कारक है, जैसे रिचेस्ट सोर्स ऑफ ओमेगा 3 and all. Yes, I am going to conclude. Yes, I am going to conclude.
Yes, sir.
Please. Yes. Within 3 to 4 minutes, I am going to conclude. So just to see here, so just to know any much more difference in big and small, but we have to see other factors also. That means how much oil you are going to use there. So we may consider accordingly and suggest our patient. Fat 11 grams, that provide 100 kilocalories. So oil 100 grams. Similarly, banaspat ghee also, animal ghee also. So these are, that means we are taking, many patients say just we are taking fat-free oil. What is the fat-free oil? They think olive oil is the fat-free oil. They think desi ghee is fat-free ghee. Okay, so just we have to just suggest them these are the myth, these are the food faddish. And similarly, when you are going to add, that means any kind of nuts and dry fruits that like almond and groundnut and all, so just you may suggest them, you are reducing 100 calorie when you are going to take 15 gram of all these dry fruits and nuts. So exchange formula always we prefer. Then lots of controversy regarding the artificial sweeteners. So it's harmful, it's not harmful, this, that. But this one is the guideline given by the American Dietetic Association. That's the aspartame is, we may suggest to our patient, that's the 40 milligram per kg of ideal body weight to our patients. And lots of research on these sweeteners, and till today just we have not found any such kind of negative impact on that. But we also know that this one, the artificial sweeteners, so just we may suggest to patient as less as possible we may have. Okay, and stevia also, that's available in the market, but the test of stevia is not up to marks, and personally just I have also feel that's not accepted by many of our patients. So just but patient if prefer to take that one, so they may have also. So this one is a simple diet chart plan. So just 1200, 1500, whatever it may be. So just we have to consider all food groups in that, the cereal, pulses, green leafy vegetables, other vegetables, fruits, milk, oil, flesh foods, all food groups should be included in their diet. Whatever it may be, the 1200, 1000, 1500, 2000, 2300, 2005, whatever it may be calorie, but we have to go with all food groups, so that give the positive impact, and that means the prevent from the deficiency of any other kind of nutrients that's happen during diabetes. So we have to plan accordingly. So this one is the dietary guideline. That's we are going to finish our lecture with this slide. So cereals, that means wheat, rice, ragi, bajra, maize, jowar, that's the preferable. Okay, limit the food prepared with maida like white bread and biscuits. Avoid cake, pastries, naan roti, rumali roti, noodles, Maggi, etc. Or even atta Maggi also, atta noodles also, because that's preserved with the salt and all. So that's not good for diabetic as well as hypertensive patient. Pulses, whole and sprout pulses and dal are the best choice. Vegetables, green leafy vegetables are always best choice for our patient. Roots and tuber may we give restriction. Fried vegetables, cheap canned vegetables may avoid. Similarly, the other groups, that's the fruits, always limit fresh fruits. No any preferable, no preferred fruits, always limit fresh fruits. Avoid dried fruits, canned fruits and syrup form. Dairy products, low fat milk, buttermilk, skimmed milk is the best choice, always preferable choice. But whole milk powder is in the limited form. That means यदि कुछ कोई option नहीं है, in that case you may suggest okay little bit of that, but occasionally. Butter, khoa, condensed milk, milk cream, etc. may avoid. Similarly, eggs, always egg white is preferable. And avoid egg yolk. Animal foods, fish is preferable. Chicken in limited quantity, prawn and all kinds of other meats may avoid. That's give the better result for diabetic patients. So fats, more than one type of vegetables oil is always better. Okay, instead of taking one single oil, total fat intake should be limited, but oily dishes, butter, ghee, coconut oil, vanaspat ghee, deep fried foods, etc. may avoid. Beverage, soup and light tea or coffee may given. Fresh fruit juice without sugar, tea and coffee limit. Cold drinks and alcohol may avoid. Salt, foods in natural state may taken. Too much salt in preparation may limit, and pickle, pepper and other salty food items may avoid. So lastly, we are going to conclude. Indians are at high risk of developing diabetes and related complications. This disease is easy to detect and can be controlled. It is advisable to follow lifestyle modification. That's very, very important. So follow lifestyle modification. So proper diet and exercise. Once diabetes is detected, रेगुलर फॉलो अप इज ए मस्ट टू प्रिवेंट कॉम्प्लिकेशंस. जब भी कभी डायबिटिक का पता चले, आप घबराएं नहीं, आप उसके लिए जो है सो अपने डाइटिशियन से मिले, अपने फिजियोथेरेपिस्ट से मिले और डाइट और एक्सरसाइज के ऊपर इसको कंट्रोल करने की कोशिश करें, और फिर एंडोक्राइनोलॉजिस्ट और डायबिटोलॉजिस्ट से मिलें यदि कंट्रोल नहीं हो रही है, और तीनों को साथ में फॉलो अप करें. डेफिनेटली इट्स गिव द गुड इम्पैक्ट, एंड वेल कंट्रोल डायबिटिक इज कॉल्ड cure diabetic. So every patient with a little care and determination can lead a long and healthy life. So diabetic को लेकर के डरना नहीं है, घबराना नहीं है. Proper diet, proper exercise and proper medication is the one of the major important factor to control diabetic. Thank you all for your patience hearing. Thank you madam.
Thank you so much, sir. As I have already told, we always love to hear you. You covered all the corners of the topic. Thank you so much for such an informative insights in the topic. Thank you, sir.
Thank you.
We will take all the questions at the end. I request all the participants, if you have any questions to Dr. Sanjay Mishra, you can drop your questions in the question box. Thank you. Like Mr. Mishra has said, dietary management is important in the disease condition, but in the time of COVID-19, it becomes more sensitive. To deliver the personal experience and research, I would like to call upon a renowned endocrinologist, Dr. Subhash Kumar. Kindly share the profile. Dr. Subhash Kumar is the Director and Chief Gynecologist, Diabetes and Obesity Care Center, Patna. Since 2001, he is having 18 years of experience. He is a consultant to UNICEF and Sayug Multi-Speciality Hospital, Patna, and also the visiting faculty at Patna AIMS. He is having the prestigious positions in many associations, like he is a secretary of RSSDI Bihar chapter, president Podiatrist Society of India, treasurer Obesity Society of India, secretary Bihar Diabetes Federation, and he is a life member of RSDDI, API, DRWA, BDF, Endocrine Society. Over to you, sir. Sir? Hello? Dr. Subhash Kumar, are you there? Dr. Subhash Kumar, are you there? Sir, your voice is not coming.
रवीना जी, डॉक्टर सुभाष सर को लॉगिन में कुछ प्रॉब्लम हो रहा है, वो रिकनेक्ट हो रहे हैं.
Okay.
दूसरी को खोल गया.
डियर पार्टिसिपेंट, जैसा कि पहले भी अनाउंस किया गया है, कंसर्न सब्जेक्ट से जो भी आपके पास क्वेश्चंस हैं, आप चैट बॉक्स में डाल सकते हैं. रितु प्रिया जी, आपने कुछ लिखा है बट वो इनकम्प्लीट आपका क्वेश्चंस है, कि इसको कंप्लीट करें. आप किस संबंध में बात कर रही हैं?
I think this question is for Mr. Praveen.
But what type of data, please clear?
Hello. Hello.
Hello, Dr. Subhas?
Are you audible? I am audible now?
Yeah, yes, sir. You are audible now.
Okay, let me share my screen plus. Maybe some net issue I am getting now.
Okay, it's okay, sir.
Okay, as my topic is introduced, we all know that we are facing an era where our whole day-to-day living has been changed, and we are going through a phase where all kind of endocrine or related issues have been cropped up. Is it visible now?
Yes, sir, it is visible. Your presentation is visible.
Okay, thank you. So, what I wanted to talk on this topic today in front of all elite dietitian of Bihar and across the country, that we have to find our own method of developing healthcare related data and its impact on the health of our society. Because as a dietitian, there is a lot of scope where you can help whole healthcare system of our state. And in this COVID era, when we want to have a new data, a new insight about the disease and its impact, not only related to medicine or drugs, but also related to diet, exercise, and other simple things which can make a big difference when we want to decide what to be done for our people. So I was very impressed by the presentation of Mr. Praveen Kumar, who is also a project director for Alive and Thrive. He was talking about quality care and how to gather data to improve the healthcare system. And my presentation is very much in the same line, that I wanted to find out what happened to my diabetic patient in this COVID-19 pandemic, when everything is standstill. You are not going out to do any exercise. Your day-to-day living has been disturbed. And India is a country where you get a huge number of diabetic population. It is to the tune of more than 70 million people, not 45 million as presented by Dr. The previous speaker. And it is still more than what we can understand. It is more than 70 million, means it is the one which are diagnosed. And you can imagine the same number of people are not diagnosed in our country, and same number of people are pre-diabetic, where you can make a huge difference when you want to take a diet issue with them and find out what is the exact situation, because no one had seen COVID earlier, and what happens to our population. So here comes my disclaimer, because this presentation was made for postgraduate and physician education, and was published in a journal also. So we have, this is the topic where we published the effect of COVID-19 on the daily lives of people living with diabetes in the eastern part of India. And it was published 3 months back in Endocrine and Metabolic Research journal. Why I'm showing you this, because I want you people also to come up with a simple technique where you can always get information from our own public, our own people, be it diabetic, be it obesity, or hypertensive, or any other related healthcare issue where diet and exercise plays a big role. And you can find out a very simple information which can be passed on to the whole of the healthcare system, and you can make changes in the lives of people. You can make changes in the government policy. You can make changes in the medical consultation ways, where the way we treat the patient or educate them. So why we wanted to take up a diabetic in a COVID situation, because there are number of papers published by different countries where they found that if diabetes is not controlled, the mortality is much higher in COVID cases, and if the glucose is well controlled, the mortality is much less. I don't want to talk more detail because this will not be of your interest, but what I want to talk is how to conduct a study and how we can easily find out the data and its related information which can help you people and all other systems. The study which we did, the aim was to understand the effect of the pandemic in people living with diabetes in our own area, because we get very few paid doctors or very few data from our own population, from Bihar or around surrounding areas. So I wanted to find, and by doing that, we can improve the management of diabetes and its care. So you know that people with diabetes with a poor control have 2/3 higher morbidity and mortality, which has been proved in several studies. So the study, whenever you want to do a study, you can have some target to find out that what answer you want to search from this any study. Like we wanted to find out the effect of glycemic control due to pandemic, and changes in the life of people, that what they are doing and what they have changed and what they should have been doing, what is the psychological status in their day-to-day living, like anxiety level, depression, and other issues due to pandemic. And if you want to, if you can find out some key answer, you can find out the key position, then you can also make a recommendation to public and government agencies. So this study was a simple cross-sectional observational study, and we just used random sample from our clinic, and there are 3 more sites across Bihar, and we used just a self-reported questionnaire-based survey in people living with diabetes. We sent them emails, and we had WhatsApp for all those patients who were diabetic, and we wanted to gather information. And we have 15 questions which we constructed to find out the exact answer from them. And it was having a choices where they can fill up, and you can find out what actually they are doing. And there are many other different technicalities are there which you can learn, or you can understand, or you can take my help if you want to conduct any such kind of survey or study in your clinical practice, or you can join and also put up a big data. And there are some inclusion and exclusion criteria. As you know that any study, if you are doing any research, you should find out which patient to be included and which patient not to be included. So people with confirmed diagnosis of diabetes you was included, and you have to define the criteria of diagnosing diabetes, and you have to see whether you want to conduct both in type 1 and type 2, or there are some different types, more different types of diabetes you want to include. So we included all these. And you have to have a COVID confirmed cases which are hospitalized were excluded, because you don't want to study this patient who are in the hospital or those who already suffered. You wanted to find out what happened to your normal diabetic patient once the COVID pandemic is there. What happened to their daily routine? Because once a person is infected and he has suffered, then there is altogether a different story for them. And there should be an age limit for anyone who can give you a proper information and give you a consent. And you should not have any psychiatric illness, because they will not give you a right answer whatever you want. And then you want, for any study, you should have a recruitment and sampling technique. The sample which included were database which was there from my OPD, as well as 2 more OPDs of different part. And you have to confirm that the patient is already on anti-diabetic therapy. And we analyzed data using relative frequency statistics. There are some difficulty in statistics, but there are people who can do study, who can do a calculation, or there are some software which I have also, that you can use different statistics to calculate different values. But for your interest, it is very simple and not much, because you have to collect data and you have to process it, and some other people will help you with the analysis of data. But there are always some drawbacks, and there are always some biases in any studies. And for my study, the drawback was the literacy level, because most of the diabetic patient who comes to my clinic are either literate or semi-literate. They are not illiterate. And if you want to find out answer for the whole population, that is called external validity of a study, you have to include all the patients, those who are illiterate as well. But in this study, we could not include illiterate people, because this is a questionnaire based survey. So you cannot talk, you cannot find, you cannot do this on illiterate people. And other thing is that we have a limitation, because we have only a patient from town mostly. So you are not touching the patient from the village side. So this is a drawback of a study. So you cannot say that external validity is very robust, but yes, you can say that at least to those patients who are in the town, you can always see that these patients are included. And for any study, you have to first do a pilot run. So we did on 3rd August 2020, that we took 20 patient survey and we studied ourselves, and we wanted to see what are the answer came, whether the answer were questionnaire were correct, and it was understandable. It was answering the questions which we wanted, and it was patient were able to understand. And once it was corrected, and final run was done on the 7th August, and we did included more 70 more patient data. and we wanted to see the answers which were given by them, whether they were all coming in the right way. And after 70 patients, we found that the response which we taken from 111 response, it was the data, the graph didn't change. It means to say that after 70 patients information, almost the graph was stable. And I'll tell you why this 111 patient only we included on those period. So these are the pilot study where we wanted to draft and find out whether the questions were correctly understood, and there are sample population which we have taken, and the first 20 patients gave their answers, and when we evaluated, so we actually calculated total 212 patients data, on which we could see that some non-diabetic patients also gave us a reply. But in the questionnaire, if a patient says that he's not diabetic, or by chance in place of a diabetic, a non-diabetic patient gets this email, or then they will reply non-diabetic, and it will be included in consequent analysis. So let us see how are the results. How we calculated the validity of the study, and how we found that the number of 111 patient is enough to conclude that the response is good enough to give a answer for the whole population which are visiting in my area. So the question was, first question we asked that, has there been any change in your eating habits due to COVID-19 pandemic, or whether the patient was having some change in their daily eating as they used to do before the pandemic. And in that, 45% they said that yes, they have changed their diet. And I'll tell you what are the details of diet in little this, because the similar study was conducted in the northern part of India by Dr. Anup Misra and team from AIMS, and they also had a different set of answer for their population. And after we calculated 70 patient, if you see the right side, the graph is not changing. The response or the percentage of response was same as 45. If even after 70, if once we did 111 patient response, it remained same, and even after that. So we just wanted to follow with the study with 111 response in our side. The second question was, have you started any new activity like yoga, exercise, or any kind of physical activity? In that, 71.2% said yes, and 28.8% said no. So these were the related to the exercise. See, by knowing all this information, you can have so many different type of information to you, because you want to advise patient about exercise, because this pandemic situation, people are scared now, they are doing some exercise. So this is the best time to educate them and tell them that you should do, and what exercise you should do. Usually 150 minutes per week is the minimum required for any diabetic person, and it should be of moderate intensity and so on. So you have to have a data to understand that this is the way you have to educate people. Is there any change in your weight in the last 2 months? Because we wanted to know that there were weight gains, and what happened to our normal people have told that they have got weight during this period, but what happened to diabetic population? And they said that 30%, 30.6%, they said that weight has lost, but almost 18.9% said that the weight has increased, and almost 50% remain the same. So maybe a tentative data, but you know that you can understand that 18 or 19% of your diabetic populations are gaining weight. So you have to look at them, and you have to find out that they should not do that. Did you change the medicine in the last 2 months? In that, 65.8% said no. Then this is not good, because you know that different situation, different weather, different exercise condition, the dose has to be adjusted. And because people were not able to come out due to the lockdown, then you have to find out that you have to do some teleconsultation, or you have to help them, or you have to make them understand that you should do adjustment to your daily insulin or your diet, your medication, as per required. This is the study by Dr. Anup Mishra. And what they could find out that there was 21% increase in carbohydrate, 23% increase in snacking, and they also increased fruit intake by 27%, and there was a decrease in 42% of exercise, and they decreased blood sugar measuring by 23%, and 87% people said they have stress. So this was the study which was conducted in Delhi, and they had some idea, and they said that the people with diabetes, they are going through a different stages of their daily living with this pandemic situation. So in our study, we also found that there is any change in blood sugar control. In that 50% they said yes, it is the same as it was before, but 25% they said there is an increase in their blood sugar level. So it just this is the small data which we captured, and we have to look at all these 25% of the diabetic patient, and these are the people who are coming to our clinic or they are in our contact, and still their sugar is increased. So we have to look at these people, and we have to find out that their sugar remains normal, because I told you that high sugar level makes a big difference in the COVID pandemic, because once they are infected, they are going to go through a very bad kind of infection. So regarding sleep and other thing, so we asked whether there is a difficulty in sleep, and then you said 59.8% said no. But if you say the similar data from Dr. Renjo et al., they said that there was almost 27.5%. They said there is a difficulty in sleeping. So maybe two country, different situation, they have different problem. But our people, they said that 40% people, they said that they have a problem with the sleeping. So you have to give them some kind of psychological support to these people. And have you had any kind of negative thoughts or stress? So they said almost 44% yes. And do you know that you can do a teleconsultation? Because we wanted to know that they can consult me on telephone or on WhatsApp or on or different media. And in that we could see that 80% people, they know that they can do a consultation to their physician, but 20% they were not able to, 19.4% they were not able to, they didn't know that they can do this. So this is important information, because maybe 111 people data suggests that, but it should be the whole diabetic population that they should know that wherever they are, they can consult teleconsultation, because Government of India has given teleconsultation as a legal way of consulting for their diabetes control or other related issues. So we have to work more hard to find out these 19.4% people, where they are, why they are not able to understand why they cannot consult, because unless until they reach to us either for the diet or for the medication, we cannot help them. So there should be more education in part of teleconsultation by the government or by us also. Are you using just a simple question, face mask? And in that, you can imagine that 95.5% said yes. I don't know how much true it is, but whatever, but 5% still are missing. So these 5% are going to cause big trouble to other people, because they will spread the infection, and they will again cause a second or third wave, as we are seeing that the new strain is popping up. So these people will not understand, and they will never help. They will become a problem for other people. And this is another study from Fernandez and group, where they had a similar issue regarding the information of virus. And in that, they said that 87% people, they know about the virus, that how it is spread and why they want mask, but still there are many people, they don't know about it. Just simple question like washing your hand frequently. In that also, you can see that almost 7 to 8% people, they don't do this. So they don't understand that how bad the disease is, and how fast it can spread to other people and to themselves. And very important question we wanted to find out by this surveys research, that have you taken a vaccine for influenza and pneumonia? Just to give you an insight that diabetic patient, especially those who are senior citizen or age more than 60, they must get a vaccine for influenza yearly and for pneumonia at least once in lifetime. This can prevent secondary infection, and even if they get a COVID infection, at least they will not get secondary infection because most of the death occurs due to these diseases. So in that, almost just say imagine 78% people are not vaccinated, and which is not good, because if you compare with other countries, they have almost 90% are vaccinated or more than that, because they have to get compulsory vaccination. In India, we have to pay our own pocket. So the people are not getting vaccinated, or maybe a part of doctors that they are not informing people that they should get vaccine, because these things are preventive measures. And government also are thinking of giving vaccine for COVID. And I wrote to the Prime Minister, depending on this data, that they should vaccinate all senior citizens, at least those who are more than 60 or those who are diabetic. They can get a much bigger protection by giving this influenza and pneumonia, because they will not prevent from these two diseases, but also if they get COVID, they will be protected from these two infections. So that was a very important finding that we could find out, and we can demonstrate that there is a big health gap in our healthcare system. Is there any social distancing? And I know that there is nothing we are seeing in our roads and markets, and people are not taking any precautions. There are many more questions which I cut down, just to give you a snapshot that if you can find out, if you have a concept of doing a research and understand, publish a paper, help the government and help the healthcare system about their situation, you can conduct a simple study like this. You can come and talk to me. You can send me WhatsApp message that you want to conduct a study. As a secretary of RSSDI, I can ensure that I'll help you in the right way to go, and you can have your research paper in your hand in a couple of months like this. And this can be published in many national, international journal, or at least RSSDI, since till I am there, till next year, I can publish in my own journal, which we do. So I encourage all dietitians from Bihar that to come forward and find out any concept in your mind that you want to research, you want to find out about your diet related issue or any other related issue. You can talk to me. So that's all from my side. Thank you.
Thank you so
Thank
much,
you,
Dr.
sir.
Subhas. Thank you so much, Dr. Subhas. We learn something new every time when we listen to you, sir. And your presentation is like full of basket of knowledge and few things which we should consider, or which we should think about it. So we will do it. So to further proceed the scientific session, I would like to call dietitian Kanchan Mala. She will further continue the session. Thank you.
Thank you, Rubina Parveen ji. Now, I would like to invite next speaker, Mr. Shiv Shankar Timanpyati sir, who will deliver role of diet in improvement of cancer patient. Shiv Shankar Timanpyati is Chief Dietitian, Tata Memorial Hospital, and Vice President IAPEN member, Mumbai chapter, Chairman IPEN Quality Award Selection Committee, and he is consultant National Institute for Research and Reproductive Health, member ESPEN Global Nutrition Program GNP, and member of MSCC Multinational Association of Supportive Care in Cancer. So please welcome, sir. Over to you, sir.
Yeah, thank you, Dr. Anupama. I'm sharing my screen. Am I audible?
Yes, sir, audible.
Yeah, thank you. So congratulations to the IDA Bihar chapter, and really it's heartening and nice to know that you people are active and doing great work. And thanks for this opportunity as well. So as I have only 20 minutes, I will directly go to the agenda. Uh, Normally, the cancer and nutrition, what has been taught in our classrooms are just 1.5 page of the entire syllabus. But believe me, my friends, it's not like that. The nutrition in cancer is much, much more than that. Even if it takes around 4 to 5 days continuously, we won't run out of the topics. There are so much to talk about nutrition in cancer, because that is one area in the last 20, 30 years, very less work has been done. Yes, of course, in the last 4 or 5 years, we are getting many studies, many new things are coming up, and things are moving in a great way. We are also learning many things, and whatever we are getting through our experiences and whatever the literatures around the world, I'm just going to share a few things with you all. But today's presentation, I have made it a little bit of kind of basic of a thing, except for this one slide. And I thought of reaching out to the uh, main content of the nutrition, not rather going with the type of cancers like cancer of stomach or cancer of intestine, colon cancer. I'm not going to talk about all those things, because as I said, it's very huge. And whatever I'm going to present it over here, it's just a part of all those the body organs and different kind of nutritional approaches, nutrition compliances, practices, guidelines. Everything is very specific to each organ. So to start with, let us understand when there is a cancer in the body. So there's a wrong signal which is being sent to the brain, into the hypothalamus, and the hypothalamus gets activated, and it starts again sending wrong signals to the body as a catabolism. It's not doing anything good. It's all signals are sent to harm the body. So it is activating the atherogenic the factors which are responsible for whatever the fat deposits we have in our body. It starts breaking down, and it is being converted to free fatty acids, and further it is being taken into the liver, where this free fatty acid which will be converted to the glucose. Similarly, when the fats are being broken down, at the same time we have a lot of cytokines are being released. As you know, nowadays a lot of things are being spoken about cytokines: interleukin 1, interleukin 6, or tumor necrosis factors, which are these are the three most important things. Of course, there are many more cytokines, but let us stick to these three more things which are really harmful during the cancer disease. So all these cytokines, they get involved into a chain kind of a reaction, and even the muscle starts breaking down. It's not that the muscles are broken down because of some requirement has increased. No, there is no requirement of any kind of energy requirement has increased, or any other reasons are there where the muscle has to be broken down. It's not like that. It is only the cytokines which are acting upon and trying to break down the muscles. And what you might have heard regarding the sarcopenia, that is, once you lose your skeletal muscle mass, then you start becoming very thin, and you don't have much energy, lot of fatigue and other things, what you see a person who is really ill, really sick. So in this process, as I said, your fats are being lost, your muscles are being lost, so you don't have any reserves in the body. So all these converted to amino acids which are sent to the liver. Liver, what does it do? Taking these free fatty acids and amino acids, it converts into the glucose. So once this glucose is being produced, this glucose goes to the tumor. So that is why even when the patient is not eating anything, still the tumor will be growing, because tumor is always getting its energy requirement through this process. So there are some studies where they say if the patient goes on fasting for a few days, the cancer cells might die. No, cancer cells will not die. They have their own resources. They have their own mechanism to get the energy derived from this process. This is known as Cori's cycle. So Cori's cycle is the one which will always keep the cancer cells alive. So, and you can't prevent anything doing to stop this Cori's cycle, because this is something like, you can say, a inbuilt or a default kind of a system where you cannot intervene and can stop this kind of process. So what happens is glucose is taken by the cancer, and while utilizing that glucose to produce energy for its own growth, the tumor, it also produces lactate. So what glucose is taken, it is sending back lactate, and what this lactate goes back to the liver, and again the liver converts this lactate to glucose, and this glucose again it goes back to the tumor. So even if you're, as I said, even if the patient is not eating anything, is starving, the same lactate and glucose through the Cori cycle, this cycle keeps on going, and the cancer keeps on getting its fuel, and it keeps on growing. Even though the patient goes on reducing his weight and losing his muscle mass, but the tumor mass goes on increasing. So this is the reason where why the patient is seen to be malnourished, catabolic, and it becomes very difficult for us to intervene and reverse all these reactions. Can this be done? Yes, to a certain extent. The big question is, yes, these all complicated matters, yes, we can understand, but what can we do as a dietitian? A big question to be answered. As I said in the earlier slide, the tumor necrosis factors or interleukin 1 and 6, these are the three main culprits in this cancer disease, where they are going to instigate lot of reactions. As I said, it is known as chain reactions. You can just imagine a patient having a cancer and who is into catabolic, all these reactions are having. I'm not going to go into detail of each of them, but let us come to a certain kind of a few things which are very much important for a dietitian to feed a patient. So it is going to reduce the gastric emptying. So the patient says, I don't feel hungry. Once I eat anything, at least for 6-7 hours, I don't feel like eating anything, because the food doesn't pass through the stomach, because there is an increase in gastric emptying. The intestinal motility, the intestine, whatever the motility, where the food keeps on moving through the intestine, even that process goes down. Not only then, as I said, a lot of you can see over here a lot of gluconeogenesis and lot of production of CRPs or SLPs, reduced production of albumin and hyperlipidemia. All these kind of reactions are going to hamper the patient's entire physiology complications. What are the metabolic activities keeps on happening, and we keep on telling the patient just to eat high calorie, high protein diet. High calorie, high protein diet has actually no role over here to play, because it has to be a specialized high calorie, high protein diet. Then only we can think about trying to do something about this cachexia, or else it's just by feeding high calorie, high protein. I know some of the oncologists during my early years of dietetics practice, they used to tell that if you are feeding the patient, you are feeding the tumor. So don't say that you are feeding the patient because you want the patient to be having a good health or increase the weight. The patient will not increase the weight, because whatever you are feeding, it is going to the tumor. Yes, but now down the line, after 10-15 years, the understanding of these tumor functions are better now. We have better literatures, better investigations have happened, and now we can understand what needs to be done. So why the malnutrition is so common among the cancer patients? Yes, we know one is because of the disease. Because of the disease, the patient is like, there is a delayed gastric emptying, or there is a bowel habit changes. Some people will say they have to visit the washroom for 10 to 12 times just to empty their bowel. So it's so difficult for them. They're scared to eat because they have to visit the washroom every now and then. So sometimes they don't have any kind of taste because of some treatments, or they don't like to see the food itself. There's a lot of anorexia, and there may be the chances that the patient may not tolerate whatever you are going to feed, maybe because of some surgical events have happened, or maybe because of the chemo radiation after effects of that, side effects. So there are so many things coming into the effect. First of all, to what you saw in the earlier slide, a lot of complications into the body. Now, whatever the chemo radiation, the doctors are going to give to treat the cancer, that itself also is inducing a lot of challenges for a dietitian to see that the patient is well fed. So when the patient is hardly eating around 20-25% of the daily requirement, how difficult for you it becomes to keep on telling the patient, you need to increase your diet, you need to increase your diet, or you have to keep on eating. No, it's not that easy. That is why our planning, our counseling, and the most important is how far you understand your patient's symptoms. That is more important. Sometimes the patient will come and say, yesterday I had 3 to 4 times of diarrhea. Thereafter, I'm constipated. I'm not able to, I visited the washroom, but I'm not able to pass the motions. So now you may be thinking, once he's saying he's having diarrhea, the second time he's saying he's constipated, or maybe one day he's complaining of a different kind of bowel habit, the second day he's complaining of a different thing. What kind of dietary interventions you are going to do for this variable kind of symptoms which are being projected by the patient? So all these things, it becomes very difficult to really understand what the patient's physiological condition, the metabolic changes happening into the body, and what kind of real diet which can be really helpful for the patient to maintain the health or maybe progress into a good health. So the challenges are very frequent and very huge, and even the feeding is always a challenge for us. And as we know, the first route is whatever the patient can take it orally, the best is to go with the oral feeds. But if it is not possible, yes, you can always recommend either for enteral nutrition or even the parental nutrition. I will just share what we do at Tata Memorial is like, whenever we feel the patient is not able to eat or consume whatever the diet I have prescribed to this patient, but is hardly able to consume around 25 to 30%. And I know if this is going to continue for more than 1 week or 1.5 weeks, I'm going to put my notes into the medical system stating that this patient will be consuming around 25 to 30% of his daily requirement. We need to really look into the possibility of putting an enteral tube for this patient, because they also keep on seeing when the patient goes for every follow-ups after every treatment, like after every chemotherapy, the patient will go to the doctor for to update the health of the patient. That time, even the doctors will go through the dietitian's notes and they see how far the patient is really consuming, what are the compliances, and why there is a poor compliance. Okay, the dietitian has recommended 2000 calories, 80 grams of protein, but the patient is eating hardly 1200 calories and around 30 grams of protein. The doctor is going to ask why you are not able to eat anything. If our recommendations are there on the system stating that the dietitian has already said that you look out the possibility of for enteral nutrition, because the patient is not going to be improving his diet in the coming few weeks, the doctor takes an initiative at that particular time and recommends the patient to go for nutrition, enteral insertion at the earliest. And if the enteral nutrition is also not possible, for example, a case like a mucositis grade 3 and 4A is reporting to you, most of the time we tell the patient, if you are not able to at the time of grade 1 or grade 2 mucositis, that time only we will tell them it's better that you go for the prophylactic. That is, before it progresses to grade 3 or 4, you better go and tell the doctor you have higher grade of mucositis and you're not able to eat anything, and enteral tube insertion should be demanded over there. And if it is not possible, yes, parental nutrition can also be considered. And maybe around 15 to 20% of our patients, even before the surgery, for around 3 to 4 days before the surgery, if intestine is blocked and they are not able to eat anything, and we tell the doctors that so this is the condition where we are not able to feed the patient and the intestine blockage is too tight that the food will not be able to pass through that junction. So it's better that the patient should be put on total parental nutrition. As a dietitian, what I mean to say is you have to take an equal responsibility from your side if you're not able to feed the patient adequately, and you see what are the reasons for that one, and put those remarks on the file or onto the system, so that the doctor also, in coordination with your recommendations, will take an early decision. Because most of the decisions are taken so late, that is why the patients, the patients keep on losing their weight, and infection and other complications keeps on rising. And when they come to you, it's too late. You cannot do anything. So that is why all these probabilities of enteral nutrition or parental nutrition should be very aggressively being monitored by yourself, and you have to recommend to the doctors. What are the benefits of nutrition cancer treatment? Earlier, no one was worried about whether you are feeding the patient or not. Everyone is focused on only the nutrition, the treatment. Now the time has changed. The nutrition has taken paramount importance in the treatment of the cancer, and everyone agrees that if the nutrition is taken care at the earliest, is the much better. Like, because if the more you delay, the more the complications are going to increase. That is why the timely intervention. nutrition. The timely intervention of nutrition is very important, because before it progresses into grade 3 or grade 4 malnutrition, where your role becomes almost negligible. So it's better that you can identify, or the doctors or the nurses at the OPD level, they can identify the patient's food consumption is very poor. They can recommend the patient to visit a dietitian and for a early intervention for that one. We don't want the patients to keep on going into a malnourished kind of a condition where a lot of nutrient deficiencies and more complications are being created. Yes, of course, if you are very aggressive and the patient is very cooperative and the patient really shows a good amount of interest in what you are going to recommend, yes, we tell the patient to gain the strength and to improve the immunity and to prevent infections. It's very important that you have a good diet, what is being recommended. Even the bowel habits, as I said, it's a better tolerance of all these treatments. During the treatment, once the chemotherapy is given, the first 3 to 4 days are a huge challenge. Some patients will be constipated for 5 to 7 days. Some patients will be having 4 to 5 or maybe 10 to 12 episodes of the diarrhea on the same day and following 3 to 4 days. So again, that is why if the patient is really following up your advices, you can really take care of it, and then the treatment will be better tolerated. Further to that one, yes, if you can achieve all these three things in a very good way, and with of course with the cooperation of the patient, what we are going to achieve is over here, like we have a faster recovery and a better rehabilitation. The recovery is faster, the rehabilitation will be much stronger. There are some conditions, there are some certain kind of cancers like pancreatic cancers or the total gastrectomy surgeries, where the adaptation might take between something around 3 months to 3 years. So that is why the adaptation of the new anatomy after the surgery into the human body, you can never predict how many days or months or years a patient can take. That is why many of the patients, even after 2 or 3 years, you can see they are not gaining their weight, or they are just with very difficult this thing, they are still not able to maintain what their weight was at the time of surgery. Even after the surgery also, when we tell them that you really need to have a good omega-3 fatty acids and good amount of calorie proteins so that you can maintain your weight, it becomes very difficult. So, but if we can achieve this on timely, this becomes more easy. Of course, many people will be talking about the cost factor for the dietary aspects. In reality, if you see the early the recovery, the less you are going to spend the money for that one. Of course, if we are going to achieve all these things on a timely way, the patient will be having a good quality of life. And once the patient is having a good quality of life, even the cancer recurrence, we can prevent it. So a whole lot of things are playing over here. And what is our approach and what the route we have? Any patient coming to you, yes, they should be screened at the OPD level. And once they are found that a dietary intervention is required, they should be immediately sent to the dietitians for the intervention. And the intervention cannot be, you cannot have one diet chart giving it to them and say that you have to follow throughout the treatment. But yes, of course, there should be a critical intervention depending upon their biochemical parameters, their symptoms, and other kind of treatments which are coming into the way. So a periodical intervention is very much required, and a regular follow-up. Once you give the diet chart, I always say that your work has actually begun, it has not ended. So that is why a regular follow-up is required. Whatever the diet you have prescribed, whether the patient is really following up or not, whether the compliance is really good or not, that you can come to know only during regular follow-up. And even if the patient still is losing his weight, and maybe because of some simple things like diarrhea or constipation, which you could have resolved. So if the patient is not coming for the follow-up, or if you're not going to call the patient for the follow-up, the patient is going to lose a important aspect of the treatment. So that is why regular follow-up is very much important. Whenever you're advising all the good foods and good food habits and other to increase the compliance, all the reasons you are giving, if your diet compliance is really poor, how you can increase the compliance. When you have advised everything, but if you're not advising exercise, all those nutrition will go in vain. So the patient is not going to benefit of all the good nutrition what you have really worked hard. So that is why the exercise, you should always say, if the patient has undergone any surgeries or have any problem with conducting exercises, so you can always tell the patient to go to the physiotherapist, or you can recommend the patient to the physiotherapist for a proper kind of exercise. So once all these things achieved, yes, as I said, the maintenance and rehabilitation, that is the last part of the our intervention. As I said, our work never gets over at the time of handing over the diet chart. It is just the beginning, and even during the rehabilitation, as we have the patients coming for the follow-ups even after 5 years or 7 years or 10 years, and we have those follow-ups in our records where the rehabilitation we keep on monitoring. All our work has to revolve around our anthropometric measurements. There are symptoms and their biochemical parameters and the lab investigations, the symptoms, the treatment, the medicines. Everything revolves around. We cannot be just looking at one particular area, that is the weight, and keep on planning the diet. You really need to go in thorough with all the anthropometric measurements. Maybe you can measure the MUSC or whatever the facility is provided by your institute to record the anthropometric measurements, because the change in the anthropometric measurements give a very clear idea where the patient is progressing into, whether he's progressing into a good or bad, or is maintaining. So you have a very clear picture. Symptoms will tell you why symptoms are so important, because the symptoms are the one which will affect the compliance of your diet. If you're not going to concentrate on the symptoms, the compliance of the diet is going to be hampered. So that is why. And as I said, the one diet will never work, because that is why lab investigations you have to follow, and always see what is the trend of the lab investigation. Never see one value. What does it indicate? If you are going to see the albumin, maybe it may be around 2.8, and you don't know the previous value of the albumin, so you don't know where the patient is progressing. So you should always see the trend of those biochemical parameters, whether they are improving, whether they are deteriorating, so that whether you can be liberal in your diet or whether you need to be more aggressive in your diet. So that will again, it will be influenced by these lab investigations. How much energy should be given? Nothing much to talk about this one. I heard some of the speakers what they're speaking about, almost similar to that one, I would say here. But no need of giving too much of calories to these patients. What is more important are the proteins. But still, how much has to be given? Yes, something around 25 to 35 kilocalories is what has been recommended. But if you see something weighing around 25 kgs, 28 kgs, or 30 kgs, you can still go beyond around 38 or 40 kilocalories. So depending upon what is your focus, you want the patient to gain weight, increase it to between 35 to 40. You want the patient to maintain the weight, who is having a good weight, so you better stick to only 30 kilocalories per body kg weight. And if the patient is overweight, you can give around, say, around 90 95 kgs. You don't have to give even 25. You can give only 20 22 kilocalories per body kg weight. So depending upon what is your focus, I want this patient to reduce weight, or I want the patient to maintain the weight, or I want the patient to gain the weight. Accordingly, you go on changing this bracket of 25 to 35, or maybe you can extend it from 20 to 40 kilocalories. Proteins are the most important requirements of all the nutrients, because if you concentrate on protein, I keep on saying the calories are definitely going to follow. But if you focus on the calories, not necessary that your proteins will be met. So that is why make a priority that you always give good amount of proteins. What are the recommendations? 1.2 to 1.5. But at our TMH, we always focus, our normal protein starts with something around 1.3 to 1.4. And if the patient is having ascites edema, we go beyond 1.5. That is 1.8 to 2 grams are also just, you can have a focus like whether I would like to really give more proteins to this patient. So even if, unless until the patient is a known CKD patient, you don't have to worry about how much of protein you are giving. So even to reach this 2 grams of protein, everyone knows it's so difficult and it's so tough even for you to recommend, and even the patient to consume that one. But yes, of course, but if your focus is clear, and if your objectives are clear, so you can always tell the patient why it is important that you need to reach these targets, so that proteins are the one nutrient which has almost all roles of physiological functions. So that is why if the patient is lacking in protein, and if you are going to provide good amount of calories, you're not doing any good to the patient. Carbohydrates, yes, I very strongly recommend that no simple sugar should be given. They are the inflammatory nutrients. And sugars, sugar is the only food item, which doesn't has a second nutrient. Even the fat has some vitamins. But sugar, if you see, except for simple sugar, that is also not good carbohydrates. That is all bad carbohydrates. So which is not required for the body. So that is why we always tell our patients, as far as possible, avoid the sugars. Only if the patient is not able to eat anything, then we say, okay, you can eat little bit of, but in a limited quantity. So see that your diet is more focused on the complex carbohydrates, and you see that the carbohydrates comprise around less than 55%. Normally we go less than 50% because we increase protein, so we decrease carbohydrates over here. Yes, of course, fructooligosaccharides and other probiotics, prebiotics, which I'm going to talk in the slides ahead. So these are all things should be a part of your diet. You just don't concentrate on only complex carbohydrates, but do you have a variety of complex carbohydrates where you are also providing probiotics and lactose-free kind of a carbohydrates and good amount of soluble fibers. Omega-3 fatty acids, this is the one thing which your diet should comprise of. But yes, of course, where you would like to increase the weight of the patient, that there you have to be very aggressive in recommending omega-3 fatty acids. At least 2 grams per body kg weight per day you can recommend. If the patient is having a good weight or maybe a higher weight with good muscle mass, there is no need of recommending omega-3. It doesn't mean the patient has cancer, you have to recommend omega-3. No, it's not like that. Depending upon the health of the patient and the muscle mass of the patient, you can decide upon whether I would like to recommend omega-3, because omega-3 is a costly one. It's an expensive one. And as you all know, being dietitian, what are the sources for? I'm not going to go in detail of these things. Whether vegetarian or non-vegetarian, you can always give the options, or you can always recommend the supplements as well. When you are giving a high protein diet, you also don't have to worry about vitamins and minerals. You know what happens? All these major, I'm not saying all nutrients are available, but major high protein source of foods, whether it's meat, milk, or maybe some seeds, all these along with the protein, they give a lot of minerals. So that is why, so you don't have to really keep on calculating whether I'm really giving a good amount of minerals and vitamins. But if you're giving good amount of proteins, you don't have to worry about minerals and vitamins. I'm not going to go in detail again for here. Deliberately, I made it more colorful. The main message over here, tell the patient to eat at least 4 to 5 different color of foods, so that a good amount of phytonutrients can be included in the diet. Good amount of phytonutrients are going to reduce the inflammation of the body and going to help the treatment outcomes in a much better way. So the patient may not really understand what are if you go on naming some vegetables and fruits. It's better that when they go for the shopping, you tell them at least every day you see that at least 3 to 4 minimum, 3 to 4. If someone can eat 4 to 5 different color foods, it's much better. You give them the options. See that you can always tell that just don't stick to 1 or 2 colors of foods, because you need to get many different kind of nutrients and phytonutrients which will come from different color kind of foods. So that make it a habit, at least 3 to 4 different color foods are being included in the daily diet. When we talk about probiotics, don't forget about the prebiotics. We talk a lot about probiotics. Probiotics are better, good. They give good amount of saturated fatty acids, which will create good amount of calories in the intestine. Everything is understood. But if you're not going to feed these probiotics, are the live microorganisms. Either you can give it through yogurt or sour cream or kefir or so, all these things you can give it. But they are always there in our intestine. But if you are not able to provide through the external sources, but if you can give the food to them, those microorganisms survive and grow depending upon these foods. These are the foods for the probiotics. But that is why every day tell them that at least 3 to 4 kernels of the garlic, if they can include in their diet, but they don't have to saute it. If they can just rupture it and they can include in the food, that will be much better. Once you saute it, the most of the good effects of garlic is being lost. Even the ginger, there are many things in our kitchen which are really very helpful for the cancer patients. Immunonutrition, again, it's a different and huge topic, but you don't have to really worry about what the earlier slides I spoke about, high protein and the different color of foods. If you can include those 2 things, most of your immunonutrients will be taken care by these 2 only factors. What are they? High protein one and the phytonutrients. If these 2 slides will summarize the entire thing, what you would like to really give over here, then you really don't want to really look into whether he is getting all the minerals, whether he is getting all the antioxidants, whether he is getting all the vitamins. So all these things you really don't have to worry about if you are going to just follow those 2 slides what I told you earlier. Immunonutrients, also there are nucleotides which are very important, because when you want to increase the immunity, it is not that you should have a good defense. You should have a best attack for also to attack the cancer cells, to attack the other bacteria which are going to affect you all. So it's better that you just see that again, I'm coming back to the high protein foods. High protein foods are going to give good amount of nucleotides, and these nucleotides have a very varied kind of a biological activities, and they increase the numbers of antibodies, T cells and NKCs, that is natural killer cells, and they reduce diarrhea. They promote the growth of good bacteria, that is probiotics, what I spoke earlier. So coming back, if you see, all the focus comes back to the protein content only. So that is why you always focus on the protein, so that most of the things are very well taken care of. Proteins are good source of fat, fibers, vitamins, minerals, so many things are there. So we normally focus on most of the walnut and almonds and a little bit of peanuts. So a combination of these three will be a very good source of most of the nutrients as well. Again, remember, there's all these dry fruits, specifically the non-sweet ones, have a good amount of micronutrients as well. So how much to eat then? We normally tell a normal weight patient to eat at least 50 grams. 50 grams means at one handful. If you fill all these, what you can see on the screen of a bowl, this is something around 60 grams or 65 grams. So one person has to really eat around 40 to 50 grams to get the benefits out of it. If they're eating 4 or 5 almonds or 3 walnuts, they are not going to do any good to the patient. So that is why whatever the amount we are eating, that is more important over there. Coming back to some of the seeds, flax seeds or black cumin seeds, apricot kernels, chia seeds, sunflower seeds, sesame seeds, hemp seeds, we all know about this thing. The only thing is we don't incorporate in our practices. Yes, of course, I'm making a general statement. It's not specific to any dietitian who is really doing a good practice by prescribing all these kind of seeds. Great. Because all these, all these seeds, they have a good anti-carcinogenic effect. They can control blood sugars, they can control the cholesterol, they can control blood pressure, they can control inflammation. That is the most important thing I keep on. If inflammation is taken care, most of the treatment outcome will be much, much better. And the many spices in our kitchen itself are very good. The turmeric, black cumin, garlic, saffron, black pepper, cardamom, cinnamon, clove, coriander, all these masalas, what we use. The only thing is, the problem what we have in Indian cooking is we saute it so hard and make it into a kind of a thing. Whatever the good qualities all these spices have, we destroy all those things. And we feel we have included all the nutrients, but why our immunity is not good? All these spices, good nutrients or the phytonutrients, or you can say all the good qualities, get destroyed when you are sauteing it. The best thing is, you can always tell them, they can keep a mixture of this thing after the food. Maybe they can sprinkle it on the food, or maybe while drinking water, they can mix in the water and they can drink. So that is the best way you can always tell them. Fluids, I'm almost ending my presentation, last 1 or 2 slides. Fluids, when any patient who is malnourished, we always think that he's not eating food. But when he's not eating food, he's not drinking water also. So that is why all malnourished patients are also dehydrated. Remember this one. So that is why our focus always drifts away from the fluids. So whenever you're recommending any food to the patient, don't ever forget to tell them to drink good amount of water, maybe at least 2 to 2.5 liters to be more practical. And if their patient is not going to listen to you, you give a higher 3 liters or 3.5 liters, so that at least they can take around 2 liters. As I said, everything done, but if you're not going to tell the patient to be physically active, you have done only the half work. So you're not going to achieve your own goals, the patient's required goals. So that is why always remember, all these nutrients have a better effect only if the patient is physically active. Thank you.
Thank you, sir. So much for very. Now I would like to next.
Any questions are most welcome. I'll be happy to answer if there are any questions.
Sorry to interrupt you, Kanchan. Just got to know that Mr. Shiv Shankar will leave our session due to some reasons. Sir, we have a question for you from Dr. Vishal Sastri. You can see in the chat box also. His first question is, what's your recommendation for patients with metastatic cancer and already developed a partial or full bowel obstruction? The second one is, how safe is TPN for liver? Does it create further complications?
Okay, fine. See, if there is an obstruction in the intestine, the only way you can feed the patient is TPN. There are some times where you can give only liquid diets, and we have seen that the patients do tolerate. Like if the opening in the intestine is a narrowed one, and a liquid can pass through, even the colorectal cancers also. So sometimes even before, if you really talk to the patient what they are tolerating, they will respond to you saying that, sir, I'm better off when I take liquids. The moment I take some solids, I'm very hugely and very it's very difficult to pass the motions. So that is a clue what you can take, and you can tell them if the liquids are being tolerated, you can recommend only the liquid diet. Liquid diets are never recommended only because they are not able to eat, chew, or swallow. No, that is a totally different part of this one. Here the food is not passing through the system. If the food is not passing through the system, only liquid can pass through the system. Yes, you recommend the liquids. Even if that is not possible, then the TPN is the only thing what is being available to you. Second, whether the TPN for liver, how safe is TPN for liver? Does it create further complications? No, TPN, you need to always have a maybe around 3 to 4 days lab investigations being done to see whether any triglycerides increases there, or any fatty liver grades are being increased, or if the patient is having any cirrhosis. Even cirrhosis is not actually a kind of a condition where you should not be giving TPN, but TPN is very much safe in almost all conditions. Very rarely we have come across any condition where the triglycerides have increased to a very dangerous level and we are thinking of stopping the TPN. Very rare. So you don't have to really think about it. Yes, of course, when you're continuing the TPN for the patient, you always tell them to do periodical lab investigations to see whether is there any liver enzymes are being compromised. So what's your recommendation for patients with metastatic cancer and already developed partial or full? That I answered. Yeah, anything else? I think both questions I have answered.
Hope, yeah, I think Dr. Shastri have got the answer. Sir, if you have any follow-up questions, you can write in the chat box. Thank you, Mr. Shiv Shankar.
Thank you so much.
Now you can continue, Ms. Kanchan. You can continue further.
Okay, thank you. Now I would like to invite next speaker, Dr. Anupam Srivastava, who will deliver improvement in maternal and child nutrition. Dr. Anupam Srivastava, she is public health professional with more than 25 years of experience in the field of health and nutrition. She has worked in the state of Jharkhand, Bihar, UP, and Orissa, at present associated with Alive and Thrive in Bihar. She has worked with CARE, UNICEF, and present with Alive and Thrive with different capacities. Please, ma'am, welcome, ma'am, and over to you.
Okay, thank you. I think let me. Okay. So the topic given to me is that improvement in maternal and child nutrition, challenges and support required from IDA and other organization. So my task has become very easy when yesterday's and today's presenter have presented about the improvement in maternal and child nutrition, especially yesterday's session. So I'll take not more than 10 minutes to share some of my thoughts based on some field realities. So if you see, just this month only, we got fact sheet about from NFHS 5, which shows that there is some increase and some improvement in the mortality rate, and some improvement in some of the nutrition practices, but this is not satisfactory. If we see that neonatal mortality rate in Bihar is 34.5 and IMR is 46.8, under 5 mortality rate is 56. This is too high. And if we see the condition of women in Bihar, it's 63, means out of 100, 63 pregnant women are anemic. And even though 63 pregnant women are anemic, the consumption of 180 IFA during pregnancy in Bihar is only 9.3, meaning out of 100 pregnant women, only 10, less than 10 women has consumed the prescribed 180 IFA during their pregnancy. And if we see the nutritional status of children in Bihar, 42.9% children are under 5 are stunted, 41% children are underweight, and around 22.9 are wasted. So altogether, if we and we can see some more, like in institutional delivery, we are doing good. 76% women are delivered in the institution, but 31% of the mother initiated early breastfeeding within the first hour of birth. Look, there 76% are giving birth in institution, and only 31% are children are given first milk within 1 hour. So there is a huge gap we see, and here the role of IDA and other development partners becomes very critical, because we are working, and IDA is especially working with the institutions. And when institution delivery has increased, so why not that initiation of early breastfeeding has increased? So there is a gap which we can think of doing something very pertinent to fill the gap. And exclusive breastfeeding, 59 children, 59 out of 100 children are exclusively breastfed for 6 months. When we talk about the first 1,000 days, or when we talk about the nutrition, the first nutrition for the child is breast milk, and we all know that it should be the child should be exclusively breastfed till 6 months. So we have done not very good. We have gone down in terms of early initiation of breastfeeding. Yesterday, Rabi and Dr. Seventy has shown the slide. That's why I am not showing that slide. And exclusive breastfeeding is also has increased, but it's not had reached the satisfactory level. And coming to the next is that complementary feeding. Although the data is not there, but
Vishal here, I think, sorry for interfering. I think your slides are not visible, at least to me. I don't know if
why Vishal?
It says Anupam has started sharing, but so could you please reshare your presentation, because I think it's not visible.
Let me do it again. Now.
Yeah, now it's visible. No, it's fine.
It's showing now?
Yes.
Okay, so then coming to the complementary feeding, data is not there, but the introduction of complementary feeding has in Bihar has improved since last NFHS 4 survey, but there is no kind of a improvement in terms of consuming minimum acceptable diet for the children 6 to 23 months. It's still 9 point something, means 10% only. 10% means out of 100, only 10 children are getting adequate amount of diet. So this is the situation of Bihar. So some of the realities which I want to talk about, that we all know that pregnancy and lactation are very important period, and where the nutrition requirement is increased, and it is very critical for the growth of the mother and child both. And when the mother is malnourished and the womb is also malnourished, it affects not only the childhood of the child, but it continues throughout the life cycle. And if a mother is malnourished as an infant, young child, and adolescent, it and she is likely to enter malnourished in the pregnancy. And if the mother is when she entered in the pregnancy being malnourished, the further increased nutrition requirement is not met, then she becomes further malnourished. So that kind of a vicious circle is there, and it goes on. And if the nutritional status is comprised, that it affects the health and nutrition of her, for herself, for the mother, and also the child. Although mother plays very kind of a central role in the well-being of the children, but her attention to the mother's food is very neglected. very neglected in Bihar context. And when we do ANC and when we talk about nutrition, we only talk about iron supplementation and monitoring of the weight gain. We don't talk about calcium supplementation. We don't talk about increased diet. We don't about taking rest. We even don't talk about deworming of the mother. Some of them, I was very surprised in my recent field visit when even field level worker like ANM and they are not aware that that calcium should be given to mother even post pregnancy, post delivery. So that 180 days norm is for the during pregnancy and after the delivery. So when the service provider are not aware of that, they are not giving it to mother. So the entire nutrition status of the mother is very kind of a compromised in both in rural and urban setup in Bihar. So coming to who influences the feeding habits, we all know that most of the families, mother has not given the freedom to decide about her food and decide about the food of the child. And even men do not participate directly anything related to the feeding practices or nutrition about their wives or children, and also for the health and nutrition. When it comes to the mother, the most of the decision related to food is taken by the head of the family, female head of the family, mostly in a mother-in-laws, who decide what should be eaten by the pregnant mother, what should be eaten by the lactating mother, and when the child should be given complementary feeding, whether the child will be exclusively breastfed. So majority of women, they are busy with their household chores, or some of the women even they work, they go to the field to do work. So and they don't think that a special diet is required during the pregnancy. So and this problem becomes more when these mother, pregnant and lactating mother, come from the resource poor settings. And there are a lot of myths around breastfeeding and complementary feeding, which I am not going to discuss now. So what are the recommended behavior? So I wanted to give you some facts, some kind of information, and that which we all are aware of. But what is the recommended behavior? We need very targeted and client specific counseling. Why I am talking about the counseling? Because this is most of IA members are doing counseling, and but the counseling should be very specific. Like if the mother of 4 months or 5 months child is coming to the hospital or any setup in the institution, so the right, although we should talk about the child should be exclusively breastfed, but start talking about the complementary feeding also. So very targeted client specific counseling is required, and nutrition education program should be integrated in other program also. Like if the immunization is there, so I have never seen and I'm giving immunization and talking about the nutrition. She gives in an immunization, she even don't talk about immunization and after effect of immunization, but nutrition education can be given at that time. And we have some poverty elevation programs which should be linked with the nutrition and health, because when the mother is in a setup, resource poor setup, then the problem becomes very high for them. And lot of follow up of positive health behavior. So once the once the IFA is given to the mother and mother starts consuming, she may have some kind of a problem. If there is a no follow up, that she is likely to drop it. So there should be kind of a follow up every counseling, so that the messages can be reinforced, and reduced workload of women to feed oneself when she is pregnant or lactating, and to feed the child. So whenever we are counseling, we should involve mother-in-law and all, and ask them to give some time to mother to feed the child and to herself. And diet diversity, I'm not going to talk about, because every speaker has talked about the importance of dietary diversity in any case, when the mother is pregnant, when the mother is normal, when the patient is diabetic, or the patient is suffering from cancer. So they all have talked in a very detailed way about the diet diversity. And income generation is also there, and focus on behavior change, because this is the crux of the entire thing. Because when we want to change the behavior, then only the existing myths and can be removed, and plus the new kind of information can be given, and that should be very much linked with the client specific counseling follow up, and that gives you a kind of a behavior change. And it is required at present. Seeing the facts of BR, we need to work more and more on behavior change communication. So what is the need of R? So support program women to have come for the antenatal care and regularly take micronutrient supplements, have safe and affordable food, and and enable them to have maternal nutrition practices. And breastfeeding is the norm forever, and in the pandemic, it becomes more and more critical. So increase access to the mother and families for skill support of counseling on early and exclusive breastfeeding, and starting from antenatal care. If you see the data of early initiation breastfeeding, we have gone down from the last NFHS 4. So we need to give more emphasis and more counseling during the antenatal period to start breastfeeding just after the birth. So it's very at this point of time, it's very important. And since we are working in the institutions, so we need to support the hospital institution to make it more mother and baby friendly hospital, both public and private. And we need to work on Infant Milk Substitute Act. This I want to kind of emphasize more here, because if you see, the use of milk substitute is kind of a rampant in Bihar, and most of the service provider and doctors, sorry to say, but are not aware about the about Infant Milk Substitute Act. So I was thinking this is one thing which we should be taking in next, to kind of orient or kind of reorient all IDA members with the support of 11th Thrive, to have kind of a to give more information on Infant Milk Substitute Act, and also seek their support to get this particular act implemented. So role of development partner, it's not only IDA, it's all IDA and other partners who are working in Bihar. So integrate nutrition education program with other programs. We have several programs. So we should integrate whenever there is a kind of a platform available, whenever there is a space available, we should start discussing or talking about the nutrition education. Do monitoring wherever it's possible, be it institution or at the community level. Whenever we go for any kind of a field visit or in the institution, just talk about, like it's become our habit, whenever we go to the hospital and we see a mother feeding or bottle feeding, we just ask why you are giving bottle feed to the child. So that kind of a monitoring is it's a prompt monitoring, or is very much required. And also plan monitoring, promote IMS Act, especially in the institution. This is very important. We need to work very strategically on IMS Act in Bihar. Understand and the data and make it usable at every level. We have got a new data, and we get every time we get monitoring data, monthly data. CARE does annual household survey. So we are very data rich state, but we need to understand the data and make it usable at every level, and ask every healthcare personnel to understand and take decision based on the data. Complement each other's initiative and support. A lot of development partners are there in the field of nutrition, and they have their own expertise, and they have their own initiatives. So let us complement each other and support each other and work as a team to fight malnutrition. This is what is coming to in my mind. And if we can do these few things, which is very, it looks very few, but it's very requires very hard work and a kind of a teamwork. If we can do, we can do better in the status of mother and child nutrition in Bihar. I think this is my light side. Thank you so much.
Thank you so much, ma'am, for very informative session. Thank you, ma'am. Now I would like to invite next speaker, Dr. Ashish Kumar, international cardiologist, who will deliver prevention for hypertension and heart disease patient in cold session. Please welcome, sir, Dr. Ashish Sinha, MD Medicine, FESC, FACC, and FCSI Cardiology, India, FRCP. Please welcome, sir. Over to you.
Thank you so much for a lovely. Am I audible? I'm not sure if I'm audible or not. Am I audible?
Yes, sir, but आपका sound बहुत कम आ रहा है.
Hold on, मैं volume देखता हूँ. Should be. अभी आ रहा है? अभी is it okay? Is it okay?
Yes, sir. Yes,
okay,
sir.
Fine. Okay. Great. Thank you so much for inviting me. And I see known faces here. I see.
आवाज स्लो है सर. Sorry sir.
अच्छा मैं क्या
आवाज
ईयरफोन हटा दूँ? ईयरफोन
आवाज बहुत कम आ रही है सर.
Okay, मैं ईयरफोन हटा देता हूँ. That would be good enough. Hold on, sir. मैं ईयरफोन.
Just 1 minute. You want us to share your slide, Dr. Ashish?
I have the slide with me right now. Let me do it. I think I can do it.
Okay.
Abhi, let me see if the voice is okay or not. Is the voice okay now? Is the voice okay now? Is the voice okay? Hello. Is the voice
yes,
okay
sir.
now? Okay.
Yes, sir. अब
Let
आपकी voice आ रही है.
ठीक है मैं let me share the slides right now. And can you see the slides right now?
Yes, sir. आपकी slide भी आ रही है.
Okay.
लग रहा है सर बट आवाज अभी भी क्लियर नहीं है सर वो.
Okay, मैं आवाज के लिए मैं सोचता हूँ. Let me.
Sorry, sir, but आपकी आवाज नहीं आ रही है.
अच्छा मैं फिर से कर रहा हूँ कोशिश कर रहा हूँ. Please, just a second. Let me check. मैं ये अपना ब्लूटूथ बंद कर देता हूँ. Much better होगी. Okay. मैं एडजस्ट कर रहा हूँ 1 मिनट. ओके. अभी सुनाई दे रहा है? हेलो हेलो.
यस फाइन.
हाँ सर अब आवाज बिल्कुल क्लियर.
ओके फाइन फाइन ठीक है. तो मैं अभी कर रहा हूँ. रुकिए. Okay, I'm sorry to, there's a little bit of glitch here. I'm sure I can hear everybody and you all can hear me very loud and clear. I'm sure I don't want to put you all in the situation. It's 31st night and it's going to be a different night for all of us. Before wasting any more time, I'd like to talk about very interesting topic which is out of the world, which is out of the league of what we are talking, what we all have talked about. It is about the prevention, and it is about the prevention in the cold season. I believe this is the time, this is the cold season what we have. I think in Patna it's around 16 degree and the minimum is going to be 8 degrees. I'm right now in Calcutta and its minimum is going to be around 12 degree tonight. So this cold season is one very interesting because, you know, this is the season where we talk about, this is the season where we get more of heart disease. This is a season where we get more of heart attack. So we have to understand about this season. We have to understand what preventive measures we need to take to make sure that our blood pressure do not go high and we don't get heart disease. So I'll go to my next slide, and we have to talk about something very interesting is the blood pressure. I believe we all know about blood pressure, and I believe one more thing that we don't know about blood pressure, because I have seen people coming to me and talking about that, Dr. Saab, I have blood pressure of more than 150 by 90 and I am okay. So I don't think I need any medications. So there are people who think, you know, that they are okay with that kind of blood pressure. See, the new data have suggested that the lower is normal. As much as low you can go without getting dizzy is supposed to be normal, because it's going to protect your your blood vessels, it's going to protect your kidneys, protect your eyes and your organs. So the new guidelines which talk about blood pressure, see, this is very important slide, because I mean, this is the slide which is going to open up the eyes of a lot of us, a lot of people right now today and probably later on, because the new guidelines, 2017 guidelines had suggested that anything less than 120/80 is supposed to be normal, irrespective of the age. See, I have seen people 65 years plus coming to me and saying, I have 160 by 90 blood pressure and I don't think I need any medication. But no, I'm so sorry, sir. This is wrong. The data has suggested that if you have blood pressures less than 120/80, your longevity is going to be more than what you are actually having. So if you have less blood pressure or normal blood pressure on medications, it's going to help you rather than going to destroy you or kill you. So this is one thing which we have to tell to all of our patients, that, you know, the data is very important. So anything more than 139 or anything more than 90 diastolic, you have to start medications. If definitely they are having heart failure, if they are having coronary artery disease, you have to start. But people who don't have any risk factors, if they don't have any risk factors, even probably the diet style modification can reduce the blood pressure. So stage one blood pressure is very important, because that is one place where you are labeled as a high hypertensive, and you can actually, with your diet and your lifestyle modification, you can go back to the normal or probably on the elevated level. So this slide we have to understand, we have to remember, either we are doctors or we are patients or we are nutritionists or whatever we are, this is one slide which is very important. And one more thing I need to tell you, that this is a slide not made by me, this is a slide which is made by the American Heart Association, American College of Cardiology, and 9 other associations in the world have suggested that this is the normal blood pressure which we have to remember, and this is the blood pressure which we need to start treating on. So they did a study on more than 9,000 patients, and they came to this data, and they found that if you have a lower blood pressure, your chances of getting heart attack, your chances of getting blindness, your chances of getting kidney failure, chances of getting stroke is less. So you don't want your patients to go into stroke and heart attack. So you better get a lower blood pressure. So now I will move on to the third slide. Like, what happens in the cold? It's cold right now. If you go out of your home, you are going to feel the cold. So what happens in the cold? What is the mechanism that explains the association between blood pressure and the temperature? Actually, it is still not explained. We don't have a direct understanding of what happens in cold. It is undetermined. So, but then there are a lot of hypotheses which actually talks about that the external temperature, your physical activity, and the hormonal changes inside your body is going to do a lot of things in your heart, which probably creates the problem. So even your vitamin D, your cholesterol level, these all have a role to play in your blood pressure. Again, remember, when your activation happens in sympathetic nerve systems activates, it releases a lot of catecholamines. These catecholamines are released due to the cold temperature. Now these catecholamines, these hormones, they have a very important role in your blood vessels. See the inner lining of your blood vessels, the endothelium. So this is what we all know, we all talk about. Because remember, when we talk about heart disease, when we talk about coronary artery disease, we have to remember that there is an inner lining of your blood vessels. That is what is affected in the cold. Your endothelial biology, the endothelial layer in your blood vessels is altered in cold temperature due to a lot of external effects or hormone effects. And that causes increase in the vascular resistance, causing blood pressure. So the cold causes a lot of things, and remember that cold kills if you don't take care of your health and body. So what is heart disease? When I talk to my people, when I talk to my patients who are educated or not that educated, but they want to know about the disease, they ask me, what is heart disease, doctor? So doctor, it has to explain the heart disease means coronary artery disease. Coronary artery disease is a vague term. Angina, the chest pain, the typical anginal pain, everybody knows about it. Heart attack or myocardial infarction, that is heart disease. What about stroke? Yes, your cerebral stroke, people get paralysis in cold seasons. That stroke is also a part of a coronary, it's a part of a heart disease. What about heart failure? You start to bloat, your legs start to swell, you have a breathing difficulty, your neck vein gets congested. So that is again in heart failure, that is also in heart disease. Your high blood pressure is all risk factors. So understand, when we talk about cold and heart disease and blood pressure, you have to keep all this in mind. Now, this is very important. How does the cold affect our heart? What does cold do to your heart? Remember the 95-degree temperature, that temperature is the borderline temperature. So if your body temperature goes below 95, when you see, we all are having this temperature gun. Right now I have this gun with me, and we always check our temperature when we go out anywhere, in a hotel or anywhere. When you see 95, that is one number which you should be scared of. See, remember, if your temperature is 95, means your body is cold. Your body cannot produce enough energy to maintain the internal temperature. So what happens if your body cannot maintain the temperature? Your body starts to show the symptoms like shivering. So you start shivering when your temperature goes below 95 degree. You have this kind of you tend to forget things. You have this tendency of confusion. You get confused. You have a lack of coordination, and then you have slow reaction to things. So your body do not respond the way it was responding when you had a normal temperature. So the cold can cause all these things, and it all can lead to death. So remember, anything less than 95 degree Fahrenheit or 35 degrees Celsius is dangerous. Remember the chill factor. In India, definitely we don't have that much of wind, but if you go somewhere else, you have a lot of wind and chill factors. If you see the the weather reports, you'll see this is the temperature, but with the chill factor, the temperature has gone still below. So what happens when you have a cold wind blowing all over your body? It takes away the heated layer over your body and makes your body still cold, cooler. So that, again, that is very dangerous, because the cold with the wind is a bad combination. So what happens when you have a low temperature? When you have a low temperature, your blood vessel starts to narrow. It starts to narrow, and the blood and the body and the heart has to pump faster and harder through those narrow arteries. That causes high blood pressure. This is very much more common in people who have 65 years or older, so especially in geriatric populations. Remember, in cold season, you don't exercise. That is again a contributing factor to your high blood pressure. You eat a lot and you gain weight. Again, that is a contributory factor. So these all factors affect your heart in the cold. So what happens in cold on heart? Your heart rate increases, your blood pressure increases, your heart has to work harder, and there is a chance of clotting of the blood in the cold. So when you have a clots in your heart, it can go to your neck, from your neck to your brain, and cause infarction, or you call it stroke. So you have more of those paralysis because the blood becomes thick. There is a high chance of blood clotting in the cold season. Okay. Again, this is a take-home slide, because this is what I have done meticulously. This you have to remember. please take a snapshot of this slide, because this is the measure which has to be taken to minimize the risk of cold weather on the heart. So how do you minimize the risk of cold weather on heart? I know we all have to go out. I know we all know that I have people waiting right now outside my home that we have to go out in cold. I cannot say I don't want to go out in cold. We all have to go out in cold. There are people who stay in -10, -20 degrees in Canada, in Russia. They all have to go out. So how do you do? How do you have you maintain your daily activity even in cold? So limit your cold exposure. You don't have to stay all the time in the cold. So even if you have to go out of your home to your car, you make sure you kind of run. You make sure you are covered adequately and go to your work. But it has to be in a limit time. You have to minimize your cold exposure. It's very important, especially for the working individuals, especially working at night. Second, in the cold season, do not vigorously work. Do not do gardening. Do not do snow shoveling or any kind of walking uphill without warming up. Sudden burst of energy is going to kill you. So remember, don't exert yourself. And the third and the most important thing is cover yourself in warm cloth. Now, I'm sure pretty everybody is confused as to how much is good coverage. Like some people wear a t-shirt and one thin cotton jacket and they say, I am okay with this. And there are few people who have to wear 3 clothes and still they feel shivering. So what is right amount of cloth which is going to help you from the cold? So again, I'll tell you, this has to be individualized. There are people who wear 2 clothes and they are okay. 1 cloth, they are okay. And 5 clothes, they are still not okay. So remember, if you start to sweat when you're outside, it means it is not good because it is too much of cloth. The warmth which is actually coming up from inside is going to dilate your blood vessels and your blood pressure can go down. So that is a bad thing. If you start sweating in your warm clothes when you're out in cold, you make sure you go back to your home, change your clothes and wear less clothes. And this is very much problematic for people who are older, age more than 60. So you remember to tell those people that don't wear 5 or 6 layers of clothes. Only wear clothes by which you are comfortable and you don't sweat. Very important, third point, very, very important point. Then you can take flu vaccine and make sure you don't drink too much of alcohol. Too much of alcohol, I mean to say not more than 120 ml of liquor, of scotch or whatever it is. If you take too much of alcohol, your blood vessels will start to dilate. Your peripheral, your arms and your ears and all those areas, they start to dilate and you start to lose temperature. So you lose temperature, your temperature goes down and your blood vessels are down. You think that alcohol is going to make you warm? This is not right. Alcohol is not going to make you warm. It's going to make you cold. So remember, it is the other way around. So in maybe 1 shot or 2 shots, you're fine. But after that, your blood vessels start to dilate and you start losing temperature. So that is about alcohol. Remember, you have to take low fat in winters because it takes time to digest those fat. And whenever you're taking fat, in moderation, of course, try to take unsaturated fat. And I don't want to talk about the unsaturated and the fat saturated because all my learned speakers before me has talked about the diet and in details. But just remember to take an unsaturated fat instead of a saturated fat. So low fat is the key in winter season. And then again, you wash your hands as we all have been washing now because of the COVID-19. Because it is going to prevent your other respiratory infections, which causes more of a heart attack. So all these factors, if you keep in yourself, if you remember it, to use it, you're decreasing the chances of the heart disease in the winter. This is my last slide, and I would like to wrap up. And this is very important slide because especially for the females right now, they complain in a different way for the heart disease. Men will complain of chest pain. Women might not come with a chest pain. They will come with an abdominal pain, and they will talk about doctor sab chakkar aata hai. Like, they feel dizzy, they feel nauseated. I have this slide which is very important slide taken from European Society of Cardiology. They have talked about the different presentations by female and the male. The female have an atypical presentation in heart disease. If they have a heart disease, they will not complain of chest pain. They will complain of shortness of breath. Saans phul raha doctor sahab. Then they will talk about nausea, ulti ka man kar raha hai. Then they will talk about tiredness. अजीब सा लग रहा है, unbelievable. I cannot explain. कुछ अजीब सा लग रहा है. So a lot of females are labeled as neurotic patients, but actually they are not neurotic. They're probably having some coronary artery disease. So doctor has to understand and check on and rule out that they are not having these kind of hidden coronary artery disease. So especially for the females, I talk about those points. So I think this is too much for all of us, and to digest this 31st night is already I believe we have past 9, and I'd like to wrap up here, and I'd like to say Happy New Year to all of you. 2021 should be good for all. I like to, if there is any question, I'll be happy to hear. Thank you and good night.
थैंक यू सो मच सर, आपका सेशन बहुत ही अच्छा रहा। स्पेशली आप जो अभी ड्रेसेस के बारे में बताएं, बिल्कुल सही बोले कि बहुत से लोग एकदम 2 कपड़े पहन के बोलते हैं नहीं इतना ठीक है, हम अच्छे से हैं, बट ये सच है कि बहुत सारे लोग ऐसे 5-6 कपड़े पहन के भी बोलते हैं कि नहीं स्वेटिंग ज्यादा अच्छा है लेकिन ठंडा नहीं लगना चाहिए। बट आपके सेशन के बाद वो लोग समझ गए होंगे कि नहीं मुझे इतना सारा कपड़ा नहीं पहन के चलना चाहिए, वो भी हमारे लिए खतरनाक ही हो सकता है।
Right, thank you.
And BP वाला सर बहुत ही अच्छा रहा। थैंक यू सो मच सर।
Welcome. So I think I can
I request all the participants, if you have any questions regarding this topic to Dr. Ashish, you can type in the chat box or question answer box. We will go ahead and take some times for question answer round now. It looks like we have few questions from Shahina Naz. Why liquid food is recommended for a patient who is suffering from gastric severe stomach pain, also back pain and spasm, if USG report is normal? I think this is for Mr. Shiv Shankar. Are you there? As he has already shared his schedule that he have to join some other seminar, so we can convey this question to him, and we will answer. We will get the answer, and we will share Miss Shahina Naz. We will share you his answers from the other way. The second one is from Basumati Panda. Which factors are responsible for creating diabetes mellitus except diet? This can be answered by Sanjay Mishra sir or Dr. Subhas Kumar. I think both are not there.
I think we have left probably, and it's time.
Yeah.
It's already, even I was late, so but it was very good for all of us to be here. And I see Dr. Farooq sir, and I hope I want to wish him a good happy.
Yes.
Yes, I also wish you Dr. Ashish. After a long gap, I have seen you. Hello.
Yes, sir. I can hear you. Thank you so much.
So nice of you. I'm looking you very smart.
So there is a question from Priyanka Raj. How to cure a mitral valve stenosis patient is the same as normal heart patient in winter. You can see the questions in the question answer box.
Oh, hold on. Oh yeah, I have the question answer. Oh, hold on. Okay.
Yes, sir.
Rich, just a second. I think how to. Oh, how to cure? Oh, viruses. See, should I answer this, Priyanka Raj?
So there is a second question also, how to prevent these cold problems, especially women.
It's the same. I think Aarti Singh, she's typing on that. I think it's the same for men and women, all the same. Again, I'll tell you because women have a different kind of feeling. See, I've seen practically not wearing too much warm clothes in winter for whatever reasons actually. So if you really want to prevent the cold problems, you have to make sure that you have at least pairs of clothing. That way you can prevent all those cold problems. So it can be an invisible cloth, kind of a thin skin color cloth, but you have to wear a layer of cloth which will trap the warm air and prevent the cold problems. So there is no other alternative to have, without having a cloth layer, there's no alternative to prevent the cold. Of course, if you can have a heater around you, if you have if you are staying inside, probably that is not an issue. But if you go out, and you have to make sure that you are dressed appropriately. For Aarti Singh.
It looks like we have covered all the questions. Yeah.
Right. So I log
Thank you,
out
sir.
then. Okay.
Thank you, sir. Thank you so much.
Thank you, Rubina. Thank you so much. Welcome.
And Ms. Saina Naz and Basumati Panda, we have noted down your questions. We will get back to you with the answers from the respective speakers. So I would like to thank you, all the participants, all the speakers in this webinar, NUTRIUTSAV. I hope we have learned a lot today. So finally, we have come to the end part of this NUTRIUTSAV. Before I close the webinar, I would like to invite Dr. Professor Pramila Prasad Madam, Vice President, IDA Bihar Chapter, for the keynote address. Thank you.
Hello, Pramila ma'am.
Respected Madam Dr. Jagmeet Madan, National President IDA, Guest of Honor Dr. Farooq Ali, Vice Chancellor JP University Chhapra, Dr. Sevanti Ghosh, Country Director Alive and Thrive, all the learned speakers, dignitaries, dietitians, academicians, research scholars, executive committee members of IDA Bihar chapter, life members of IDA, each and everyone who is participating in this 2-day webinar, which is named as NUTRIUTSAV. Namaskar and greetings to all for New Year 2021, which is to come in just few hours. Me As a senior and founder member of IDA Bihar chapter, it have to brief the valuable and informative talks, speeches, and research papers which have been delivered in this two-day event. First of all, in the inaugural address on 30th December 2020, the Vice Chancellor of JP University Chhapra, Professor Farooq Ali, introduced the theme accurately, which is highly appreciated because he agreed to do so on our request in last moments when we came to know that Sri Alok Kumar, Director ICDS SPD National Nutrition Mission, would be unable to inaugurate the webinar due to other urgent assignments. The learned speaker, Dr. Sevanti Ghosh, Country Director, Alive and Thrive, India, nicely described about ensuring maternal nutrition during and beyond COVID-19 pandemic. Thousands of mothers gave birth to the babies during this pandemic to save the mothers and to their newborns. Expecting mothers and to keep them healthy has been a great challenge. Dr. Ghosh presented the comparative data where our country and Bihar stand on all the parameters of maternal health. She focused on diversity of food which can improve the maternal health. Professor Jagmeet Madan, our National President of IDA and Principal of a renowned Autonomous Institute of SNDT Women's University at Mumbai, has thrown light on the main theme, maintain healthy life through ensured balanced nutrition, challenges and possibilities in present situation, that is COVID-19 pandemic. She emphasized that high quality veg protein and non-veg protein is essential in any stage of life. Food from every food group should be included in our diet. She said very truly that no single food or no single micronutrient can do any miracle. Mr. Ravi Parhi, nutrition specialist, UNICEF, Bihar, spoke about sustainable development goals and reflection of India as well as Bihar. Mr. Parhi said that to minimize the impact of COVID-19 on nutrition and mortality, we should improve the coverage and quality of programs. Focus should be given across lifespan and especially on vulnerable groups. Mr. Rajesh Kumar Goswami, oncologist, director, Sun Cancer Hospital, Patna, presented his research paper on prevalence of cancer and preventive management takeaway. He expressed that prevention from cancer is best. For this, awareness among mass population is the solution. Passive smoking is more dangerous. He focused on types of cancer and their early diagnosis. Dr. Sharla Yadav, senior scientist, ICAR, Central Potato Research Institute, Patna, has spoken about ensuring micronutrient in maternal and child nutrition through NutriGarden. He described the advantage of staple vegetable potato, moringa, and green leafy vegetables. Dr. Yadav showed the photograph of a specialty attractive purple potato, which has been developed by the agriculture scientists to have good keeping quality and nutrients like vitamin C, vitamin B, zinc, potassium, and 3 gram protein in one medium-sized potato. The project director, UP and Bihar, Alive and Thrive, Mr. Praveen Kumar Sharma, presented his lecture on learning of faculty-based quality improvement in nutrition services. Poor quality health care in hospitals contributes 50% death. So health system should improve its services. Some steps Mr. Praveen Kumar suggested to improve the healthcare services. Mr. Sanjay Kumar Mishra, Chief Dietitian, Paras HMRT Hospital, Patna, spoke about diet management in diabetes and hypertension. Mr. Mishra described the modes of diabetes treatment, diet, exercise, medicine, education, and awareness. He beautifully presented the diet chart in diabetes. Distribution of nutrients and calories according to meal was also suggested. Fat from veg sources is healthier than fat from animal sources. Researches prove that mustard oil is healthier than olive oil. Lifestyle modification has been advised. Mr. Shiv Shankar Timan Pyati, Chief Dietitian, Data Memorial Hospital, Mumbai, emphasized the role of diet in improvement of cancer patients. Medical nutrition therapy, nutritional assessment through anthropometric measurement, physical examination, and lab investigation should be regular. No too much nutrition is emphasized. There is no consensus. There is no consensus on nutrition requirement. It depends on individual patient, but emphasis must be on first-class protein and complex carbohydrates. Phytonutrients, that is 5 colors of food, is recommended. He elaborately spoke about the role of diet in cancer patients. Dr. Anupam Srivastav, Senior Program Manager, Alive and Thrive, Patna, threw light on the role of IDA and other organizations in improvement of maternal and child nutrition. She pointed out the challenges and support required from these organizations. Malnutrition begins in the womb and continues throughout life cycle. A little improvement in excluding breastfeeding and complementary feeding is noticed, but much more have to be done. She focused on nutrition education and awareness programs by all the development partners. We should work as team. Dr. Subhas Kumar, Diabetologist, Secretary, RSDI, Bihar, presented his study on COVID-19 in diabetes among people of Bihar. Dr. Kumar has used self-informed information through WhatsApp, emails, but this study did not include the illiterate and rural patients. Only literate urban patients were among his study. In his survey, one thing was remarkable, that lifestyle changes in several patients during pandemic was noticed. He suggested to conduct more studies to understand the change of behavior in COVID-19 pandemic. Dr. Ashish Sinha, interventional cardiologist, Bellevue Clinic, Kolkata, and KK Nursing Home, Bhagalpur. He talked about preventive measures for hypertension and heart disease in cold weather. We should limit our cold exposure. We should not exert extreme without warming up. we should not become we should not do overexertion. Alcohol must be avoided. Get to be vaccine, flu vaccine replacement should be saturated fat with unsaturated fat, and washing the hands to avoid infection is must. I think all the speakers have been covered. Thank you. Jai Bharat, Jai Bihar, Jai IDA.
Thank you so much, ma'am. Thank you so much for the motivating speech.
Happy New Year, which is to come in just few hours.
Yes, thank you so much, ma'am. I would like to request our another member, Dr. Professor Farooq Ali sir, Vice Chancellor JPU Chhapra, guest of honor, our guest of honor for this evening. Please, sir.
Hello.
Hello. Ji, sir.
I think I am audible.
Yes, sir. You are very much audible.
Okay, so nice of you. So it was a rather endurance test for all the IDA persons, including me. So taking that much of time, say 3.5 hours yesterday and exactly 3.5 hours today, totally comes to 7 hours. And in compassing all the speakers, they have taken up in a very nice way, presenting all the aspects and facets related to nutrition. And especially when we consider that the more the victims who have fallen prey to COVID-19, they are basically the persons suffering with diabetes, persons suffering with hypertension, persons suffering with the lung problem, other asthmatic. So those are also suffering from renal problems. So certainly this nexus is associated with somewhat of the non-communicable diseases, and diet plays a very crucial role in that. And here the intervention from the IDA is more required. So I think from this virtual attempt, we should take up all these issues in the real form also. So that we can dissipate this knowledge, understanding, and our expectations to the common masses, so that this is carried forwards for a better tomorrow, better health, a better new year. So we all hope. From my side, I express my basketful thanks to all those who were responsible to organize such a very nice webinar, and especially the anchor for today, Ravina. She deserves commendation, and along with Pallavi, who did nicely study, along with Manoj, who has very nicely coordinated the class. So once again, I thank you all the team of IDA, Bihar chapter, and along with all those speakers, of whom Mr. Ashish was my student also in TNV College. So after 2 or 3 years, I have seen him through IDA. So thank you very much, and I extend my heartfelt greetings and New Year's wishes for happy, prosperous, and healthier 2021. Thank you very much.
Thank you, sir. Thank you so much. Thank you so much. For vote of thanks, I would like to request Dr. Manoj Kumar, Secretary IDA. Dr. Manoj Kumar.
Arvina ji, please call to Dr. Mamta Kumari for closing remarks.
Okay.
For the concluding remarks, I would like to request our convener, Dr. Mamta Kumari Madam, IDA Bihar chapter. Ma'am, please give your remarks.
Thank you, Rubina. 31st December 2020 has become very special day for us. We had today the very learned and experienced speakers of their concerning field who has delivered their talk on the occasion of NUTRIUTSAV 2020. Mr. Praveen Kumar, Project Director, UP and Bihar, Alive and Thrive, is playing an important responsibility of 2 states. We are obliged to have him with us. Dr. Subhash Kumar, Diabetologist, Secretary RSSDI, Bihar. I acknowledge him for his study and talk and valuable suggestions and for sharing his experience during pandemic. Honorable Mr. T. Sri Shankar, Chief Dietitian, Tata Memorial Hospital, Mumbai, for such a nice topic and experience. Dr. Ashish Sinha, Cardiologist, Bellevue Clinic, Kolkata, and KK Nursing Home, Bhagalpur, is the son of our home city, Bhagalpur. We are proud to have him as a speaker in NUTRIUTSAV 2. Senior Program Manager, Alive and Thrive, Patna, Dr. Anupam Srivastav, has taken lots of pain to organize such a wonderful webinar in this pandemic situation. Shri Sanjay Kumar Mishra, Dietitian, Paras Hospital, Patna, is associated with the members of IDA Bihar chapter for a decade. When he was in the executive committee of Orissa chapter, we are very glad to find him with us. Dr. Pramila Prasad, co-convener Bihar chapter and founder president of our Bihar chapter, has been actively participating in all our activities. Finally, to conclude, Dr. Manoj Kumar, Secretary Bihar chapter, and all our members of Executive Committee, without their efforts and participation, it would be difficult for all of us to organize such a knowledgeable and informative session in this COVID-19 pandemic situation. Kanchan Mala, Rubina, moderator of this session, along with all live members, registered members of this NUTRIUTSAV 2020, who has made this virtual event so successful and lively. Thank you. Jai Bihar chapter. Happy New Year 2021. Thank you once again.
Thank you so much, ma'am. On the behalf of our partner organization, that is the Alive and Thrive, I would request Dr. Anupama Srivastav madam to conclude the, please give the concluding remarks. Dr. Anupama ma'am.
Thank you, Rubina.
Thank you, ma'am.
I have very few sentences to make a concluding remark that it was planned in a very short period of time, and it is very well executed, and a lot of work has having gone behind the curtain. And thank to the entire IDA team to selecting the very pertinent, very experts in the field of diet and public health, and all of them have delivered the way we desired. And thank you so much, the entire IDA team and entire Alive and Thrive team. And we have worked in a very coordinated way, and that has given a very, very good result. I just got a kind of a feedback from Vishal Sastri, who is there. He has written that although it being 31st of December, this today's program is very, very good. So I wrote back to him that we should write and give this remark to the group. So thank you all. And whatever we have learned, we have certain messages to take it home and work on in the next year. So wishing you all a very, very happy new year. And we need to keep working and working very hard to improve the nutrition status of mother and child and all family member in Bihar. Thank you all. Thank you so much.
Thank you so much, ma'am. For vote of thanks, I would like to request Dr. Manoj Kumar, Secretary IDA Bihar Chapter. Dr. Manoj Kumar, over to you, sir.
Thank you, Rubina ji. Before the vote of thanks, you are requested to all, please share the camera view for a screenshot.
Yes, there is a mandate protocol कि हम कोई भी conference seminar में जाते हैं तो एक last एक group picture होता है. Although it is not suitable in this situation, but we can manage it through our photos. So I would request all the participants, if possible, please अपना video on कर लेंगे ताकि एक photo लिया जा सके. Still we are 61 in number.
विशाल सर से रिक्वेस्ट होगा कि कैमरा व्यू के लिए आप अलाउ कर दें. Now after 2 days का वेबिनार का समापन समारोह एक अंतिम जो हमारी प्रक्रिया है धन्यवाद ज्ञापन के साथ हम करने जा रहे हैं. हमारे काफी गुरुजन, हमारे टीचर, पदाधिकारी, आईडीए के सभी लोगों ने, एम ने सारी बातों को कंक्लूडिंग एंड क्लोजिंग रिमार्क्स हो चुका है. सर्वप्रथम इस ऑर्गेनाइजिंग कमेटी के जो पैट्रन थी डॉक्टर जगमीत मदन मैडम, प्रिंसिपल एसबीटी कॉलेज, एसएनडीटी यूनिवर्सिटी मुंबई एंड नेशनल प्रेसिडेंट ऑफ इंडियन डायरेटिक एसोसिएशन इंडिया. सो उनका मैं आभार व्यक्त करता हूँ. अभी तो मैडम नहीं है, बट मैं उनका आभार व्यक्त करना चाहूँगा. साथ ही उनके बाद जो इस पूरे कॉन्फ्रेंस की चेयरपर्सन थी प्रोफेसर डॉक्टर प्रमिला प्रसाद, जो इस आईडीए बिहार चैप्टर की फाउंडर, चैप्टर प्रेसिडेंट भी रह चुकी हैं, उनका काफ़ी सहयोग रहा. मैं उनका आभार प्रकट करना चाहूँगा. इस पूरे टुडे वेबिनार के जो उद्घाटन करता थे श्री आलोक कुमार सर उपस्थित नहीं हो पाए किन्हीं कारण से, लेकिन सर का काफ़ी सहयोग रहा, उनका सजेशन रहा, तो मैं उनका भी आभार प्रकट करना चाहूँगा. प्रोफेसर डॉक्टर फारूक अली सर हमारे इस कॉन्फ्रेंस के एज ए गेस्ट ऑफ ऑनर थे, और सर ने काफ़ी अपना कीमती समय 2 दिन देकर पूरे वेबिनार को ऑब्जर्व किया. इससे हमारे सारे स्पीकर्स एवं जो ऑर्गेनाइजिंग कमेटी थे उनको काफ़ी मोटिवेशन मिला है. तो थैंक यू सर देने के लिए. आपका आशीर्वाद हमेशा इसी तरह इस पूरी बिहार की टीम को बना रहे, और आगे भी किसी प्रकार की कोई जब न्यूट्रिशन और माल न्यूट्रिशन की बात बिहार में हो तो आपका योगदान हमेशा रहता है, आगे भी रहेगा, ऐसा हम उम्मीद करते हैं. अगेन सर आपका आईडीए बिहार चैप्टर की तरफ से बहुत बहुत सारा आभार. मैं आभार प्रकट करना चाहूँगा हमारी चैप्टर कन्वीनर डॉक्टर ममता कुमारी, एसोसिएट प्रोफेसर फूड एंड न्यूट्रिशन डिपार्टमेंट तिलकामाई भागलपुर यूनिवर्सिटी भागलपुर. डॉक्टर ममता मैडम का हमेशा पॉजिटिव व्यू रहता है आईडीए बिहार चैप्टर को ग्रोथ करने के लिए, कि किसी भी तरह का जो भी एक्टिविटीज करनी हो तो कि चैप्टर में जो हमारे मेंबर्स हैं उनके हित में हो, वो हमेशा रेडी रहती है. सो थैंक यू मैडम, आपका भी आभार प्रकट करते हैं. मिस्टर प्रवीण कुमार जो 11th हमारे इस पूरे ऑर्गेनाइजेशन के एसोसिएट पार्टनर थे, उसमें प्रोजेक्ट डायरेक्टर मिस्टर प्रवीण कुमार जो बिहार और यूपी के प्रोजेक्ट डायरेक्टर है 11th पे. सर बहुत बहुत आपका धन्यवाद, आभार, अपना सहयोग किया आईडीए बिहार चैप्टर को, तो आपका आभार प्रकट करते हैं सर. ऑर्गेनाइजिंग सेक्रेटरीज में रचना सिन्हा हमारे साथ थी 11th से. विशाल शास्त्री, डॉक्टर विशाल शास्त्री जी थे, मैं उनका भी आभार प्रकट करना चाहूँगा. साथ ही हमारे मेंबर्स जो ऑर्गेनाइजिंग कमेटी में थे, जो हमें सहयोग कर रहे थे। मैं इसमें सबसे ज़्यादा तो मैं थैंक्स कहना चाहूँगा डॉक्टर अनुपम श्रीवास्तव मैडम को, जो सीनियर प्रोग्राम मैनेजर हैं अलाइव एंड थ्राइव को। काफ़ी कम समय में उन्होंने इतने अच्छे से डिज़ाइन किया, इतने अच्छे से सपोर्ट किया और हमसे ज़्यादा कहीं-कहीं वो काफ़ी सिंसियर होके इस प्रोग्राम को ऑर्गेनाइज़ किए हैं। मैडम हमेशा हम लोग भी अपने बिहार के हित के लिए और बच्चे और माँ के मदर्स के हित के लिए, उसके न्यूट्रिशन हित के लिए हम लोग भी आगे इस तरह से मिलकर काम करेंगे, ऐसा हम उम्मीद करते हैं। सो अगेन आपको बहुत-बहुत धन्यवाद IDA बिहार चैप्टर की तरफ से। हमारे ऑर्गेनाइजिंग कमेटी में राजेंद्र प्रसाद थे 11 थ्राइव के से, उनका भी मैं बहुत आभार प्रकट करता हूँ सर। हम लोग का अच्छा रहा कोऑर्डिनेशन और हम लोगों ने मिलकर अच्छे से ऑर्गेनाइज किया और आगे भी हम लोग इस प्रकार का कार्यक्रम को करते रहेंगे ताकि जो अवेयरनेस गतिविधि एक्टिविटी है वो जारी रहे। थैंक यू सर। डॉक्टर संदीप कुमार हमारे ट्रेजरर इंडियन डायबिटिक एसोसिएशन बिहार चैप्टर के, वो ऑर्गेनाइजिंग कमेटी थे, उनका भी आभार प्रकट करना चाहूँगा। रुबीना प्रवीण जी अभी आज के मॉडरेटर भी हैं और स्टेट कोऑर्डिनेटर हैं प्रधानमंत्री मातृत्व बंधन योजना की। और ये एम्पावरमेंट की बात है कि मैं रुबीना जी के बारे में बताना चाहूँगा। एक छोटा बेबी है उनके गोद में अभी भी और वो इस महिला सशक्तिकरण की उदाहरण है कि आज वो एंकरिंग कर रही थी, मॉडरेट कर रही थी इस पूरे, और उनका डेडिकेशन हमेशा रहता है IDA की तरफ से आप सो थैंक यू रुबीना जी, आपका स्पेशल थैंक्स। आपने काफ़ी कीमती समय निकाल कर और बच्चे को ध्यान में रखते हुए इस कार्यक्रम का मॉडरेट किया है और थैंक यू। सुषमा सुमन जी डिस्ट्रिक्ट कोऑर्डिनेटर, इनके बारे में बताना चाहूँगा। आज भी उनका डिस्ट्रिक्ट में DM सर के तरफ काफ़ी एक अच्छा बड़ा प्रोग्राम था जो कि पूरा अप्रिशिएट करना था पोषण अभियान एम्बेसडर टीम को, और उन सारे वहाँ भी कार्यक्रम को ऑर्गेनाइज करते हुए वो कल भी मॉडरेट की थी और आज भी हमारे साथ वो टीम में सहयोग कर रही है। सुषमा सुमन जी आपका भी बहुत-बहुत धन्यवाद। पल्लवी जी कल IG कल वो मॉडरेटर के रूप में काम कर रही थी। पल्लवी जी आज भी उपस्थित हैं, IG IMS में चीफ डायटीशियन है। मैं पल्लवी जी का भी काफ़ी आभार प्रकट करना चाहूँगा। वो ऑर्गेनाइजिंग कमेटी की मेंबर भी थी। जोसेफिन पीटर कुर्जी हॉली फैमिली हॉस्पिटल में चीफ डायटीशियन है, वो हमारी एक मेंबर ऑफ ऑर्गेनाइजिंग कमेटी में थी। हिना रहमत चीफ डायटीशियन है महावीर कैंसर हॉस्पिटल में। अभी वो अपना कैमरा ऑन किया, आप देख सकते हैं उनको। उनका भी काफ़ी सपोर्ट रहा, बैकग्राउंड सपोर्ट काफ़ी था। जो हिना जी थैंक यू आपको। नाहिदा समन रूबन मैटरनल चाइल्ड हेल्थ हॉस्पिटल में नाहिदा जी चीफ डायटीशियन है। नाहिदा जी का भी कैमरा ऑन हो गया है, सो थैंक यू नाहिदा जी, बहुत अच्छा सपोर्ट रहा आप लोगों का। कंचन माला चीफ डायटीशियन मेडी पार्क हॉस्पिटल पटना, कंचन माला जी आज की मॉडरेटर भी थी। कंचन माला जी का काफ़ी बहुत-बहुत धन्यवाद जी। और अंत में पूरे जो हमारे इंडियन डायबिटिक एसोसिएशन चैप्टर की लाइफ मेंबर्स हैं, एनुअल मेंबर्स हैं, उनका मैं आभार प्रकट करना चाहूँगा। साथ ही ऑर्गेनाइजिंग कमेटी के अलावा जो हमारे स्पीकर्स जो काफ़ी कम समय में समय निकाल कर इस समय दिए, इसमें सबसे पहले डॉक्टर सेवंती घोष जो कंट्री डायरेक्टर हैं अलाइव एंड थ्राइव की। हम लोग को लगता है कि कंट्री डायरेक्टर हैं, बड़े ऊँचे पद पर हैं, लेकिन उनका जो सिंपल व्यवहार हमेशा रहता है। इसके पहले भी काफ़ी समय मौका मिला है उनको सुनने का, फिजिकल भी एक कॉन्फ्रेंस वगैरह में, और काफ़ी अच्छा प्रेजेंट भी करती हैं और अपने एक जो न्यूट्रिशन में इंटरेस्ट है, मेटल न्यूट्रिशन में, उसमें काफ़ी सहयोग करके काम करते हैं। डॉक्टर सेवंती घोष मैडम का बहुत मैं आभार प्रकट करना चाहूँगा IDA की तरफ से। उसके बाद हमारे डॉक्टर प्रवीण सर जितने भी स्पीकर रहे, मिस्टर रवि परिसर न्यूट्रिशन स्पेशलिस्ट, कल उनका प्रेजेंटेशन बहुत ही अच्छा था और जो उसने एक सस्टेनेबल डेवलपमेंट गोल्स के बारे में जो बताया, ग्लोबल हंगर इंडेक्स के बारे में जो उन्होंने बताया है, और आज भी उनसे हमारी बात हुई है लगभग 1 आवर, और काफ़ी वो बिहार के न्यूट्रिशन को लेकर काफ़ी चिंतित थे कि स्टेंटिंग वेस्टिंग ये 5% 2% घट जाने से क्या हम अब आगे कैसे काम करेंगे, नहीं करेंगे। चूँकि उनको कल का प्रेजेंटेशन काफ़ी अच्छा लगा था जगमीत मदन मैडम का, वो बोले कि IDA के साथ कैसे काम किया जा सकता है डाइट डाइवर्सिटी पर बिहार में, उस पे सोचना चाहिए। तो थैंक यू रवि परिसर, आप व्यक्तिगत इंटरेस्ट लेकर बिहार के बारे में सोचते हैं। सो अगेन थैंक यू। डॉक्टर राजेश गोस्वामी जो सीनियर ऑन्कोलॉजिस्ट हैं, उनका भी काफ़ी कल अच्छा इन्फॉर्मेटिव सेशन रहा। डॉक्टर सरला यादव अभी पोषण अभियान के साथ मिलकर एक इनोवेटिव प्रोजेक्ट भी रन कर रही हैं, जो कि उसमें जैसे कि मैडम ने भी ब्रीफ किया कि पोटैटो में कैसे आयरन और कैल्शियम को रिच करके बच्चे को खिलाया जाए ताकि जो उसका डेली का रिक्वायरमेंट न्यूट्रिएंट है वो फुलफिल कर सके। इस पे भी रिसर्च किया जा रहा है पटना सेंट्रल पोटैटो रिसर्च इंस्टीट्यूट की तरफ। तो इस प्रकार से माल न्यूट्रिशन को कम करने में, नॉन कम्युनिकेबल डिजीज को कम करने में काफ़ी सारे इंस्टीट्यूशन, ऑर्गेनाइजेशन और डेवलपमेंट पार्टनर्स काम कर रहे हैं, और मैं चाहूँगा कि IDA इसी तरह इसके साथ ही बढ़कर मिलजुल कर काम करे ताकि अल्टीमेटली मेरा जो गोल्स है कि माल न्यूट्रिशन कम हो, जो नॉन कम्युनिकेबल डिजीज हो वो कम हो, तो हम सब मिलकर उस टारगेट को अचीव करने में सफल रहेंगे। हमारे स्पीकर आज भी स्पीकर हमारे डॉक्टर संजय मिश्रा सर जो चीफ डायटीशियन है पारस हॉस्पिटल के, उनका भी हमेशा सहयोग रहता है। और एक वो प्रेजेंटेशन हो जिसके ऑर्गेनाइजिंग कमेटी में भी वो हर तरह से वो अपना सहयोग करते हैं। डॉक्टर संजय मिश्रा का धन्यवाद। RSDI के चैप्टर सेक्रेटरी डॉक्टर सुभाष कुमार सर का भी बहुत बहुत धन्यवाद। कम समय में उन्होंने समय दिया और उन्होंने रिसर्च स्टडी जो कोविड-19 को लेकर दिया है, मैं तो काफ़ी इंटरेस्टेड था और मैं उनसे बात भी सर से करूंगा कि आईडीए इसमें इन्वॉल्व होकर कैसे आगे जो कोविड-19 पैंडेमिक का अभी भी सिचुएशन से उबरा नहीं है, तो यदि इस तरह से कोई केस स्टडी है, चाहे वो डायबिटिक पेशेंट हो या हाइपरटेंसिव पेशेंट हो, मिलकर हम लोग स्टडी कर सकते हैं, जो वो काफ़ी यूजफुल होगा आगे के लिए। डॉक्टर आशीष सिन्हा सर, बहुत-बहुत धन्यवाद सर। अपने आप कोलकाता से अपने काफ़ी व्यस्त टाइम लेकर अपने जो है व्यस्त टाइम में अपने समय निकाल कर बहुत अच्छा लगा हमें कि डॉक्टर फारूक अली सर के स्टूडेंट हैं। और डॉक्टर फारूक अली सर के वैसे तो यहाँ काफ़ी स्टूडेंट हैं, हम भी स्टूडेंट हैं, लेकिन अच्छा लगता होगा सर को कि एक उनका स्टूडेंट आगे बढ़ के इस तरह आज के स्पीकर के रूप में काम कर रहा है। तो डॉक्टर आशीष सिन्हा सर, बहुत-बहुत धन्यवाद आपका। डॉक्टर अनुपम मैडम का भी आज था। शिवशंकर 2020 जो शिवशंकर जी, आप टाटा मेमोरियल कैंसर हॉस्पिटल जो कि इंडिया का सबसे बड़ा कैंसर का हॉस्पिटल है, और मैं बताना चाहूँगा कि आईडीए कॉन जस्ट आफ्टर 5 डेज के बाद आईडीए कॉन है, और आईडीए कॉन में उनका बहुत बड़ा पूरा 1 डे का सेशन है कैंसर पर, और उसकी तैयारी में वो काफ़ी लगे हुए हैं। वो काफ़ी समय नहीं दे पा रहे, लेकिन मैंने एक बार रिक्वेस्ट किया और अब अपना व्यस्तम समय निकाल कर वो समय दिए हैं, क्योंकि 5 को भी आईडीए कॉन का वर्चुअल आईडीए कॉन है और उसमें पूरी तैयारी में लगे हुए हैं शिवशंकर जी। और टाटा मेमोरियल हॉस्पिटल में जो पेशेंट का लोड है, इसमें चीफ डायटीशियन है, और उससे में शिवशंकर जी का समय देना मैं बहुत-बहुत आभार करता और धन्यवाद ज्ञापित करता हूँ। थैंक यू सर आपको। हमें बहुत खुशी हुई कि हम अपने कम समय में हमारे अच्छे-अच्छे स्पीकर्स और अच्छे डिग्निटरीज हमारे इस वेबिनार में समय देकर इस वेबिनार को संपन्न कराया। और जितने भी हमारे पार्टिसिपेंट जुड़े हुए हैं, मैक्सिमम वो डायटीशियन हैं, न्यूट्रिशनिस्ट हैं, होम साइंस के स्टूडेंट हैं, फैकल्टीज हैं, टीचर्स भी कई जुड़े हुए हैं। मैं सबको प्रणाम करता हूँ, आभार प्रकट करता हूँ। एक बार मैं सब पुनः सारे टीम को धन्यवाद ज्ञापित करते हुए अलाइव एंड थ्राइव के पूरे ऑफिसर को, टीम को और पूरे आईडीए टीम को धन्यवाद ज्ञापित करता हूँ। थैंक यू टू ऑल। शुभ रात्रि।
Thank you. Happy New Year to all.
Thank you so much.
Thank you.
Happy New Year, everyone.
New Year.
And definitely we will meet next year as NUTRIUTSAV 3. Definitely on this platform or the another platform.
Right.
This platform.
रवीना जी, एक इंफॉर्मेशन भी है, 10 जनवरी को इंडियन डायटीटिक्स डे है, सो स्पेशली आईडीए मेंबर्स प्लीज कोऑर्डिनेट एंड ऑर्गेनाइज एक सच ए नाइसफुल प्रोग्राम। सो इंडियन डायटीटिक्स डे में हम लोग फिर मिलते हैं, या वर्चुअल या फिजिकल एज पर सिचुएशन।
Okay.
Good night. Happy New Year.
Good night. Happy New Year.
Everyone, Happy New Year.
Happy New Year, everyone.
Vishal.